lot of work in telemedicine. Currently, he is working as a consultant hepatobiliary and pancreatic and laparoscopic surgeon and therapeutic endoscopist in Institute of Medicine Maharajganj and Norvik Hospital. He is also the immediate past president of Hospice Nepal. And I'll also like to request Mr. Pawan Sakya to chair this session. He's the executive director of for ICT for the development. So I'd like to request our chairperson to start the sessions. Thank you.
Okay, a very warm good morning to everybody. Thank you for inviting us as chairs of chair. And without further ado, we'll try to stick to times. First speaker is Dr. Aarti Shah. Yes. The title is Telemedicine in Urban Healthcare. Dr. Shah completed MBBS from Nepal Medical College and MD in General Practice and Emergency Medicine from the Institute of Medicine, Maharajganj. She is also a distance fellow in diabetes from Christian Medical College, Vellore, India, and an executive member of GPEMAN. Currently, she is working as a medical director at Urban Health Promotion Center. And it's all yours. Thank you.
Thank you, sir. So good morning and namaste. I am Dr. Aarti Shah, and for the next few minutes, I'm going to talk about telemedicine in urban healthcare. Well, here I would like to add, unfortunately, at the institute I work, we don't have telemedicine facilities, but I see the broad spectrum of telemedicine, and I feel why we need telemedicine and how we can proceed with telemedicine. That is what I'm going to talk about in today's presentations. So moving forward, first of all, I would like to inform you that the total population of Nepal is 29 millions and the urban population is 6 millions. As we all live in a part of technology, it is a growing part of sorry. So as we all live in a world of technology, it has been growing as a part of healthcare system. And telemedicine is a part of technology. Telehealth, telecare, mHealth, these all are the subsets of telemedicine, which deliver the healthcare services and informations So it can be synchronous or asynchronous, where the interaction might be between the doctors to the doctors or doctor to the patients by various means, like through video chats or other means that benefit both the health and the convenience. With wide variety of applications, telemedicine has been used in different fields like patient care, education, research, video conference, remote monitoring, and in various purposes. We all know that NASA efforts in telemedicine begins in early 1960. Talking about Nepal, Kathmandu Model Hospital NRAIN and Nepal Wireless initiated a pilot project in 2006. However, later in 2009, it was launched by Health Ministry, but unfortunately was discontinued. But again, the IntelliCare Nepal was launched on 1st October 2020 in Dareldura. There are various centers which are using telemedicines in Nepal, in Kathmandu, Pokhara, Dhulikhel, Dolokha, Karnali, and many other centers which are using telemedicine. The ultimate goals of telemedicine in urban healthcare is nothing but to establish the standard care, rendering a diagnosis, treatment plan, and advice. The development of system based on both the decisional support and as well as training and educations. Similarly, regular monitoring of intensive and emergency care and the extent to reach to hard to reach populations. And of course, to shift the paradigm of at right time and at the right place. If we talk about the needs of telemedicine in urban healthcare, traditionally it was used in rural areas, but with the recent development of e-health services, it has grown. It has led to the growth in urban health service. There was an article published in December 2020 by American Health Information and Management Association, which say that there was a great demand for child psychiatry in urban area. So there are various expect that telemedicine can take care of, like teledermatology, telestroke, telecardiology, teleradiology. These are the beautiful aspects we can help to assess and to give the standard care to the patient. Similarly, timely access to trauma services and monitoring of intensive and emergency care are life-saving procedure. And I feel it's us of telemedicine care. With the help of telemedicine, we can improve the diagnosis, better treatment, and management. Quick and timely follow-up can be done. And as well as I mentioned earlier, the continuing of health education and training, which is beneficial, it can be assessed through this. And most importantly, access to electronic health record. After the COVID-19, after the pandemic COVID-19, I think telemedicine has merged its wing. It helps to prevent the spread of COVID-19 flu and other infectious disease. Doctors use telehealth appointment to pre-screen patients for possible infectious disease. So this has been used as a critical tool to prevent the spread through less exposure. And this has been using through the era during the COVID era at our centers, at different centers of Nepal. Telemedicine can convert and convince the patient with early diagnosis and treatment with access to specialized healthcare. It definitely reduces the visit to a specialty hospital and reduce the cost. Because of it, it's possible for patient to talk in real time with practitioner to the computer, smartphone. Patients can participate from anywhere, from home, health centers, schools, or emergency room equipped with telemedicine connection to doctors. Family connections. When consulting a doctor, it's always good to have a family member who can provide information, ask questions, and take note of your doctor's answer. For a country like Nepal, where most of the family members are across the world, telemedicine add a value of these connections. If we have access, if we have access or we authorize to have the family participant via virtual consultations. So as I mentioned, the needs and the benefits of the telemedicine, there are the various challenges we have to face. And because of we, the country of Nepal, and we, the urban people, are not been able to implement the telemedicine. There are various challenges like lack of proper regulation, registration, authorization of the health professional, lack of proper compliance, and maybe the availability of the specialist doctor in the urban area. Doctors not fully convinced and familiar with telemedicine, patients' fear and unfamiliarity, lack of basic amenities, technical constraints, and of course, government support and regulation, standard implementation, and etc. So with this, I would like to conclude that telemedicine is a boon to a country like Nepal. Registered medical practitioner with proper training and legislation will improve and expand the access of standard healthcare. Telemedicine can meet the need of healthcare to diverse the population at the community level, both rural and urban. Thank you.
Arati, thank you very much for keeping time. I will give you a timer at 12 minutes, next speaker, and we'll have the question session later, I think, in the end.
Thank you, Doctor. The next presenter is Sanjay is not here. Mr. Abhimanyu Pandey. He's my colleague in ICT 4D. Abhimanyu, the floor is yours.
Namaste. My name is Abhimanyu. I work in a small nonprofit organization. We basically are researching different ways of providing simple, repeatable, replicable, and contextually relevant solutions to rural health in Nepal. So there's a lot of words put together, and at some point, obviously, we'll share these slides. But basically, we are looking for evidence-based approach to rural health. So today, I'm going to go through a couple of historical background of SDGs and how telemedicine approach can perhaps address some issues. I'll talk about data. I'll talk about quantification, how SDGs were built and how a metrics approach helps us and also sometimes hinders us. And then talk about some telemedicine approaches that we have taken to address them. So I'm going to take you back about 30 years. As the Cold War, came to an end, people started thinking, okay, now what? Let's do something nice for this world. And if those who remember, there used to be something called a Y2K bug, and everybody was talking about that, and somewhere in the late 80s, early 1990s. At the same time, people got together in Rio and they said, okay, let's think of the 21st century, because that was the most important thing. And they created an Agenda 21. They had a couple of things going on at that time, basically health, education, poverty, and so on and so forth. That was kind of limited to the 21st century, but then people realized, hey, look, it's also the change of the millennium, is not just the century. So they started talking about, okay, MDGs. And there's been a lot of criticism about that. And eventually they said, okay, it was a very donor-centric approach. So they said, okay, even the millennium is not enough. We need to think even larger. So they started talking about SDGs. And SDGs are somewhat comprehensive. Most of them are sort of targeted toward 2030. And there are about 17, of which number 3 is about health. And this is where our focus is today. This is a bit of a comparison, and I've tried to give sources where I can. If I haven't, I apologize. I will update the slides. So this is what I really want to talk about. So let's say somebody gives you a whole bunch of crude oil in front of your house, 10 billion barrels. What are you going to do with it? You can't sell it. You don't have ways of transporting. You have nothing you can do with it. So you have all this crude oil, but you can't use it. This is what's happening in many countries across the world. We have tons and tons of data. NEA knows each and every house because they need to collect money. So they will know where the house is, the owner. Do they share that data? NTC knows. Many other organizations have tons of data. How do we get all this data together? So we know where people are living. We almost know all their ages. We know who's in their house. But when it comes to really helping out the people, do we have the data? No. And this is the problem. This is a real problem. And I don't have a solution for you, but at least we should be able to be honest and frank with each other, with ourselves, and say that, yes, there's tons of data, but it's all raw and we don't know what to do with it. Now, SDGs are, they're about 14. They have a very interesting numbering scheme. After 3.9, they go to 3.A, B, C, D. So, but my focus, I mean, we can talk about all these SDGs in health. It'll take a couple of weeks, but let's talk about the first one. It's really important. It's MMR, maternal mortality rate. And this is what SDGs, less than 70 per 100,000 live births. It's an absolute number. This is the absolute minimum. Developed countries are in the 13, 14, 5, 6, if you see the European countries. Nepal used to be in the 500s. They did a lot of work. It has somehow plateaued in the 250s, but there's still a long way to go. So there are two indicators. And now this is what's happening in terms of numbers and data across the world. This is not Nepal, this is across the world. So we still have a long way to go. From 2000 to 2020, things have improved considerably, but a lot more can be done and must be done. So now, and this is basically the core of the presentation. So SDGs, they talk about numbers, they give us aspirational goals, and it also gives us freedom. Each country has a freedom of how to do it. SDGs don't tell us how to do it. They tell us where to go, where to reach. Now, I know there will be people who'll say, put an MRI in every village. I mean, you know, a multi-million-dollar system. That's not going to help. We always forget something that it's actually at the end of the day, it's the doctors who count, the nurses who count, the people who actually provide care, the community leaders, the health volunteers. So unless that is not in order, unless that is not audited, unless that is not continuously improved, it's not like you do it once or twice or one training session, but almost each and every day. Until we don't do that, it will be extremely, extremely difficult. Sorry about that. So this is what our organization has been thinking about. We have tried to implement in many places, from home to community to self-screening. I think this is a controversial statement, but a lot of health, we keep focusing on the doctors and the nurses, and you know, this is what we didn't get. But how about the personal responsibility? So about taking care of our own health, you know, when this is a true story. I don't have the video recording, but doctors have told me in rural health communities, medicines which are free, pregnant women will take. Those which cost money, they will say, oh, we'll do that later, or we'll think about it. So where is that personal responsibility? Not just for that going to be mother, but for her entire family. Even today, those medicines aren't that expensive. They can afford it. But that responsibility, that personal responsibility for the new life which is coming on this planet, I think is also something which we need to focus on. Patient health records, a lot of speakers have spoken about that over the past day or two. We have worked, and disclosure and truth, we have worked with Bamni and Sunyaik. So definitely I'm biased towards that. I've also seen DHIS2 records. Unfortunately, those are not available that readily on government websites. I don't know why. If data is available, maybe some researcher, maybe some informatics scientist, he could come up with a better model than I have. I think AI does play a part, but we should not succumb to new temptations so quickly. And at the end of the day, in rural Nepal, getting data to feed AI systems might not be the easiest. Over the past couple of years that I've worked through, from Khotang to Solukhumbu and Dei Lake in Western Nepal, I realized that the simplest solutions are usually the best implemented. Technology has to be at the SMS level. Viber, WhatsApp also becomes complex. And there's one story from Khotang I'd like to relate to. During COVID, they got some grant and they built this isolation center. By the time they built it, the isolation center was almost, and they told me that they're going to make a multi-purpose building or something like that. And I said, hey, wait. If you have this room and there are tons of beds and all that with proper ventilation, why don't we think of a pregnant woman's hostel or a dormitory? So when she's about 6 or 7 months pregnant or with some risk analysis factors, bring them over, keep them there for a month or 3 weeks before delivery, and that might just help. And I don't know how if they implemented it or not, but I thought that was a pretty interesting concept. They also thought it an interesting concept, but implementation is, of course, based on them. I think over the years, health volunteers have done a great job. But let's take an example from FAA USA. When each flight takes off and lands, there is one handler for flight because there are thousands of flights across North America. So why not assigning one individual for every pregnant woman? And that person, whether male or female, takes care of that entire 9 months. It's intensive. It's an intensive process, but the cost of having lost a life just to pregnancy, just to childbirth, I think it's worth it. This morning I was discussing with my friend here, and how about just a small mobile phone as a gift? We do pay certain incentives for ANC checkups, maybe a small mobile phone that we can reach them out, that if they don't come back, it's, in the market, it's about 1,000, 2,000 rupees, maybe $10. So these are new and innovative solutions. And this is what's happening in certain places. In Karnali, there's a helicopter rescue for pregnant women. We need to, if they need certain help. Unfortunately, the women who really get help are those who are politically connected. Now, I have nothing against that. A woman is getting help. Her baby is being delivered safely. She's safe. That's great. But people who really need it sometimes get missed. And how long are we going to run helicopters? At the end of the day, there are about 753 municipalities. Why not have an MDGP and a small CSOT in each place? It doesn't cost that much. At the end of the day, it does not cost that much. But are we willing to put our effort into that? How many MDGPs are there in this country today? And I know the answer, but I just don't want to tell you that. But these are things to think about. And I know NSI minimum support and service standards work, and I think that's great. But unfortunately, just like SDGs, these are metrics-based approaches, which is good, but sometimes we are trying to solve the numbers game without trying to figure out a long-term strategy. And that is also a criticism of SDG. So that's about it for me. And I'm certainly not a medical professional. And if there are suggestions, criticisms, I'd be more than happy.
Thank you. We will discuss the very nice presentation and very important also. And next is the Dr. Raju Thakal from Rehabilitation Center, Nepal. Its title is Telerehabilitation Nepal for people with spinal cord injury and acquired brain injury, a feasibility study. He's a medical director in Cirque, Nepal. So you have 15 minutes. Give you warning at 13 minutes.
Everything organized. So, okay, so I'm going to present telerehabilitation in Nepal for people with spinal cord injury and acquired brain injury. I myself, Raju Dakal, and my colleague Hari is there. So, okay, next slide. So I'm going to present one video. You can see that video of our telerehabilitation project. Is it? If it's not working, I can do it later.
Share screen rather than
YouTube video, sir.
Share the audio.
Yeah.
So please select to share audio again. Yeah, it's okay. Screen is okay. Okay.
Okay.
Musculoskeletal injuries and chronic pain, requiring long-term and lifelong rehabilitative care. But specialist rehabilitation in Nepal is nearly non-existent. There is no government specialist rehabilitation centre in Nepal. The Spinal Injury Rehabilitation Centre is an NGO-run 51-bedded unit who do their best and treat such patients from all 77 districts of Nepal and provide inpatient rehabilitation for 300 individuals every year.
So traditionally, the rehabilitation, people has to go to the hospitals or rehabilitation center. But for the people who have some disabilities, they can't move. For those people, the concept of telerehabilitation is really helpful so that they don't need to have to travel, and we can provide the rehabilitation services and distance consultations while they are at home.
For patients and their carers, it can take up to 2 days to travel to the centre from more remote areas. Attending the centre can see patients incur considerable travel costs. These can be as much as 6 times the cost of a consultation in some cases.
बसेर पनि के अरे बोल्दा हुने
हुने त्यस्तो चाहिँ हुन्छ
सजिलो राम्रो नि मलाई त अब उहाँ खोटाङदेखि अब आउँदा जाँदा अब जुलुम भइसक्यो
आउनु जानु मात्रै 30,000 लाग्दो रहेछ एकचोटि चढ्नु बित्तिकै 15,000
बसेपछि बोल्न पाउँदा औषधि किन्नु पाउँदा त्यो राम्रो हुन्छ
तपाईँ खोटाङमा भएपछि तपाईँले त्यहाँ हामीलाई कुरा गर्ने अनि तपाईँलाई आवश्यकता परेको चाहिँ हामीले सके जति तपाईँलाई गर्ने अनि उहाँले चाहिँ अब के तपाईँबाटै सुरु गरिदिन्छ हामी भन्दै हुनुहुन्छ हुन्छ ओके हजुर अनि कहिले जानुहुन्छ खोटाङ तपाईँ यहाँबाट अब कति
This project will help us understand whether the teleconference system could be applied to rehabilitation to manage people with long-term disabilities. And it's exciting that it's come at the right time when the government is prioritizing such technology, and it's part of Nepal's e-health strategy 2015.
One of the first patients to experience a telerehabilitation service was Mr. RN. Mr. RN is a 25-year-old man who was left with weakness in all 4 limbs after traumatic injury to his cervical spine. He received initial rehabilitation in the rehabilitation centre and was discharged home to his family when he was able to self-propel his wheelchair and was independent in his personal care. Once home, he deteriorated. His family unfortunately left him. He was unable to leave his house, developing pressure sores and living with incontinence. He had no way of using his wheelchair to move beyond his house due to the difficult terrain and no suitable paths that can be used by a wheelchair. The social worker from the rehabilitation centre visited Mr. RN and used the telerehabilitation system to connect via a video link to a multidisciplinary team at the rehabilitation centre. The team were able to identify the needs of the patient and provided remote interventions via the social worker. The social worker helped regarding better management of daily activities, alongside helping with management of his mobility, bladder, bowels and pain, as well as skin care for his pressure sores. During the January visit, the UK team and partners at the rehabilitation centre had very productive discussions with the Nepal Health Secretary, Mr. Kajiraj Baral, and Ministry of Health, Information Technology and Health Services teams. The UK team and partners at the rehabilitation centre will be actively involved in developing telerehabilitation and specialist rehabilitation services in Nepal. An evaluation of the telerehabilitation service is underway and findings will be reported later in 2020.
So in this way, this telerehabilitation project with University of Leeds is very important, and thank you so much University of Leeds for providing us grant to run this project. And I think this is just the beginning. We want to continue this project throughout the year. Okay, thank you.
So after this small video, because I want to show this video just how we have started our telerehabilitation system in our hospital. So now I'm going to present about the outcomes of our project. Raju. So actually, the spinal cord injury and acquired brain injury is complex conditions which causes significant causes the disability, and also the people who have this type of problem usually they couldn't reach to the hospital, and also in context of Nepal there is no long-term rehabilitative care. Their quality of life is not as expected. So and also for the traveling to them to the hospitals from even for the urban and rural area is challenging. That's why the tele-rehabilitation services is very important for those people which where we can use rehabilitation services by information and communication technologies. So can I go with this? Okay, so this tele-rehabilitation project, we aimed for the feasibility and acceptability of tele-rehabilitation service for spinal cord injury and acquired brain injury. They are discharged from the specialist rehabilitation center, and also to explore how the tele-rehabilitation approach influence the outcomes relating to their functional independence, some mental functions, and the quality of life. So this study was a prospective cohort feasibility study done in the community settings for the patient with spinal cord injury and acquired brain injury discharged from the specialty rehab hospital. And they were connected with the multidisciplinary team of the spinal injury rehab centers, and data were captured. And at the same time, in-depth interview was taken, and then different outcome measures tool was used. So for that, we got ethical approval from Nepal Health Research Councils and the University of Leeds Ethical Approval Committee. And our main inclusion criteria is like the patient who rehabilitated in our center and who needs at least 1 day of travel to come at the center. So we use different medium like Facebook, Messenger, WhatsApp, Viber, Insta, VC. Initially, we try for our own software, but it's not that much useful for the patients. That's why we use whatever medium is easier for them. And then the main team involved was the physical medicine rehab doctors and other rehab professionals. And total participants were 97. So, and then we use TDAR checklist, why, what, who provided, how, where, and when, like such type of checklist we use before going the intervention. And basically we found the mean age was around 38 years, and mostly from the Bagmati province, and 80% spinal cord injury and around 20% brain injury. And 40% of the people, they couldn't move outside the home without assistance. So then we found many problems like the pain, some bowel bladder issues, mobility issues, some mental issues, and other issues for where we did our tele-rehabilitation intervention. For pain, spasticity, for bladder, bowel management, we use different medications, and also we prescribe some exercises and taught them virtually. And also we provide some assistive products, mobility aids, and also some general advice from the tele-rehabilitation system. So we did in-depth interview with our patients. Then we found, like, the male SCI patients is very much extremely important for them, because being in a wheelchair, once they discharge from my centers, it's almost impossible for them again to come for the follow-up. That's why this approach is very important. And most of the participants were very much positive about this project and about this concept. Caregivers were also very happy when we reached them through the tele-rehab system. And they also suggested us that if there are some, if we can develop some mobile apps for the brain injury and spinal cord injury, it will be very helpful for them. So we found, like, we did like DASH, depression, anxiety, and stress assessment, and we found there is significant improvement in their mental health. And also in the quality of life, we use EQ5, D5L domains that increase their mobility, self-care, and usual activities. And also their pain and discomfort were significantly reduced. So a take-home message is telerehabilitation in context of Nepal for complex conditions like spinal cord injury and brain injury is feasible, and the telerehabilitation significant improvement in functions and quality of life, and also somehow in mental health. I think the telerehabilitation system has to be integrated in strengthen the healthcare system. So after that, we published 2 papers in the international journal. So thank you so much for hearing, and you all are welcome to our center.
Thank you. Thank you, Doctor.
For a nice presentation. Now we have next online speaker, Dr. Anil Suwal. His title is Evaluation Opportunities and Challenges of Telemedicine in USA. He is family physician, member of Informatics Clinical Advisory Team, High Reliability Organization Committee, Patient Experience Advisory Committee, Physician Advisory Committee for EPIC in different time frame in Valley Health Urgent Care, and Occupational Health Board member from March 2023. He is also founding member of Himalaya Free Clinic in Virginia in 2022. Dr. Swal?
Good morning, everybody. Can you hear me okay?
Yes.
All right. Thank you, Dr. Pradeep Vaidya. I know you when I was like a medical officer back home. We'll talk about later on. But first of all, good morning, everyone, and namaste, and ohayo gozaimasu to some of the Japanese friends out there. And I know I was supposed to be presenting yesterday, but I messed up my date and time. So I guess that this is a one perfect example of challenges of telehealth, what we're talking today. And again, I want to thank you, Dr. Uday and Dr. Subhas Pakurel for connecting me to these wonderful people. So speaking of this, telemedicine, I think it is always good to know what is the history. History, we can learn a lot of things. So if we look back on the telemedicine, we can find the article way back in 1879 in the Lancet. They talk about this like a telephone visit to reduce the unnecessary office visit. So, you can imagine like at that time, there's only telephone. And so they were even thinking about using a telemedicine at that point. But, obviously at that time, there's a very limited resources. And goes back to 1925, the landmark, when this, inventor Hugo jumps back, he thought of the idea of like seeing a patient remotely, and actually he wants to touch the patient too. And this is the device he developed over here. You guys can see that. It's called teledactyly. So he thought about that way back in 1925. But, obviously, again, resources, availability, those things is not easy. So it didn't really implement very well. Next slide, please. So now on the next slide, you can see like this thing doesn't like go to the e-visit concept until like the 1960s when the government started, putting a lot of money on the research and innovation in the telemedicine thing. And actually in 1970s, we have the first EMR, electronic medical record, founded at that time. And, back then still we have very limited on the computer and software and all those kind of things. Next slide, please. And so talking about the EMR, I know we talk about EMR. Oh, yeah, it's a documentation, like a electronic documentation. It's not only the electronic documentation we talk about. The components of EMR should be like right from the patient registration thing, scheduling thing, prescription management thing, document management, and sharing the communication between the physicians, clinical decision support. There are a lot of other things, requesting and receiving lab, X-rays, CT scan, all those kind of things. So those all things need to be considered when we talk about electronic medical records. Next slide, please. So again, like I said, until like a 21st century, we don't have like so many smartphone, PCs, internet. So even though they develop all those technology, the patient doesn't have all those access. So you can't really have those things. So that's why, on the 21st century, when the smartphone is more available, everyone has a computer, that's when they started having something like a Teladoc platform, AMOL platform, which Dr. Sanjay yesterday talked about this thing too. So these are the, first like a telehealth platform founded in the USA. And then, again, there's until like a COVID time, it wasn't very popular at all. So after like a COVID, it's just exponentially grown on the telehealth side. And with that, a lot of like a digital medical devices, apps, software, a lot of HIPAA compliance platform, everything, like evolve. And nowadays, every corner globally has a telemedicine thing. So next slide, please. So, can we go to next slide? We talk about now, what is a telemedicine? No, sorry, let's go back one more, go back again on telemedicine / telehealth. Okay, so on we talk about what is telemedicine? What is telehealth? I know we use interchangeable telemedicine, telehealth, same thing, right? But if you have to define correctly, some of the association say a telemedicine is basically practice of the medicine through the internet. Now telehealth, has a little bit more broad aspect, so it has other digital like a health service, like a health coaching, health education, teleconferencing, all those kind of things comes under the telehealth. And mobile health, obviously, I have iWatch here, iPhone here. It is feeding a lot of data. It tells me at the end of the day, hey, you have 10,000 steps. You need to go 2 more thousand steps. So these are all the part of a mobile health we talk about. And the digital health, it is even a broader, where you have all informatics, technologies, personalized missing thing, like a remote patient monitoring, all those things, that will be all like a digital health. Now, can you go to next slide, please? So having said that thing, let's just talk about here, consulting with Dr. Uday. Dr. Uday is a physician out there, I'm a patient here. And so I talked to him, yes, everything goes well, and just kind of like a FaceTime, right? There's nothing much in telemedicine. Now let's just slice it down. How much component does it have? We just always talk about take it for granted. Oh, okay, we did a FaceTime, went great, but let's just slice it down and take a look, what are the different components we have. Here, first of all, communication devices. You need to have a smartphone to have those better communication. And now with that, of course, you need to have something like a digital medical devices. Like I have here, like a digital like a stethoscope. So if I put on my chest here, Dr. Uday can listen my heart. Dr. Uday can listen my lung. And actually, I can even get a nice EKG on my device, and which I can forward to Dr. Uday. So he is getting all real-time messages of my health through the internet thing. So this is the digital medical devices we are talking about. So there's an electronic otoscope I can put on my ear, and I can show to Dr. Uday, this is what my ear looks. So there are so many digital medical devices we can use to leverage that, challenges of not able to examine properly kind of thing. And obviously it has to be, a quality thing. We'll talk that down the road. Now, next part, after digital medical devices, you see there's an internet there, now is it safe? Am I putting all the data over here? Like I said, I took the picture of my skin. I sent it to Dr. Uday, and I know Dr. Uday is using correctly, but they are in between the internet. A lot of people can't get that one. Some people picture of mine might be viral. Somebody can get that one and put on a media and it went to the viral, which I don't want. And so who is, talking about, those compliance thing, privacy thing, is somebody monitoring on that? So this will all comes under something like a medical software, how compliance it is, what is the privacy, and, different medical apps we are using. And, like I said, like internet connection is another part. Unless we have a very good internet connection, you will be very choppy. I'm talking and then you have to wait for a little bit and hear. So that won't give you the good experience at all. And, at the end, you need to be willing to be, like seeing a patient through this telemedicine thing, which we call like a web manner. We call like a bedside manner in our old medicine time. Now we call it a web manner. You have to be very like a focus on that. You need to be engaged to see a patient. And that's something very important part of like the telemedicine too. I call it a kind of like a building block. Again, we may not have everything, available, but, when you're doing the telemedicine, always try to think through this thing. What I have, how can I leverage this thing? How can I make this thing a little bit better? Next slide, please. So these are some of the medical devices we have here in the United States here. You see like a, eardrum there. There's a little something called TytoCare. Like every patient actually can have that. This costs about $300 or something like that. But you can see that, the doctor is on a tablet there and then, taking a temperature of the child, and actually you can see the eardrum, listen to the heart, listen to the, like a lungs and everything, and even have a good, like an eye exam. And there's EKGs there with a, like a stethoscope. And the smartphone is connected with so many different medical apps and devices. The doctor can get all the feedback directly. But once again, it has to be reliable. We're going to come that down the road. But there's a way. If there's a will, there's a way. So next slide, please. Now, I want to take you back a little bit on this here, like a patient experience. I don't think I've seen a lot of people, we talk about technology and, like a challenges, but we never think from like a patient side. I really think we all need to think from the patient side. If the patient doesn't have a good experience, whatever care you are doing, that's not going to be, like make a difference. They're not going to come back. Let's just take a look on this old gentleman here. He's like, looking on that small, teeny tiny, like iPhone. He might be talking to the doctor, but he's having a hard time seeing even a doctor. Do you expect him to come back again in the, you like a Zoom or something like that? Does he have a trust on you? You are providing good quality? Probably not, So let's flip back to like on another side here. There's a holographic image. It is not, widely used here in the United States. We still don't have this kind of capability everywhere. But holographic, there you can like present the whole person in front of you. So what if like this person see this like a whole doctor, like a holographic thing? Will that make a difference? Probably yes. He will probably feel better about that. And look at this like another picture here. The doctor is with the, like doing the Zoom call or a video call or something like that. And he's a very well dressed and he seemed to be engaged. But look at the background over there. There's some light coming there. It's a very glary. That can affect some of your patient. Let's say your patient has a migraine. They may not like this kind of like a background out there, right? And if you, let's say like there's some like a ceiling fan running and you are seeing the patient may get dizzy. So be mindful of what you have in the background. That can make a difference on your patient too. And that will not make a good experience. Now look at this hospital bed where the patient is actually comfortably sitting there, and but the patient has a some kind of assurance that, oh yeah, my heart is being listened by the doctor, and she can see the doctor very well. And the bottom one, doctor is telling the patient what to do, how to do, and so. Think about this thing. This is probably the hospital patient where there's a more availability of like good devices, right medical apps, all those things that will make a patient experience better. And think about this. If they like it, they will come back again. So once again, patient experience is one of the very important things. Technology, you can make the best equipment in the world, but if your patient is not using, that's not going to be useful at all. Next slide, please. So after that, again, we can say there are different branches of telemedicine. You can use as a telestroke, radiology, psychiatry, dermatology, ICU, urgent, a lot of things. And one of the good things here in the United States, a telestroke program has gone very well for the last several years. A patient might be, 2-3 hours away, but they got a CT scan in the hospital. Even though they don't have a neurologist, they will look all those images and they actually start, a medicine right away. So this is going very well. Again, like I said, telemedicine can be used anywhere, everywhere, like a telesurveillance, telediagnosis, teletriaging, telemonitoring, teleeducation. You just name it. It's there everywhere. You just have to have a wish to do that. Next slide, please. So again, with all these things, obviously there's some limitation too. We need to have a good law. First of all, we need to have what is the standard care. Can I just call everybody in let's say Viber or some kind of a Zoom and talk that, and is that a standard care? Where is the HIPAA compliance? So you need to define the standard care. What is a standard care for your area, geographic area? And standard care for United States might be different than the UK and obviously from Nepal. So we all might have a different kind of strength and weakness, but we all have a different standard of care. So you need to think about what is the standard care of the practice in your setup. And then again, the patient privacy, do you have a law for that? You're doing the, let's say I'm doing a teleconsultation from Dr. Uday. Now, is he allowed to practice here? For example, a lot of a Nepali doctor in a lot of foreign countries these days, are they allowed to do telemedicine in Nepal? We need to have a rule and regulation for those things. And again, even in the United States, there's a state to state, a different regulation and everything is different. So telemedicine law is definitely growing in everywhere. We are learning, one step at a time, but that is something, we all need to work around. And another big part is, a medical app and device. Now, everybody can make a medical app. If you're a genius, some electronic person, an engineer person, you can make medical apps. But does that work? They claim it is working, but is that true? Who's regulating that? So that kind of thing. Here, FDA regulate all the medical devices and apps. So do we have all those regulated medical devices, regulated medical apps? So we need to question that, if somebody comes and say, hey, this app is very good, why don't you use this one? And this will give this. But, we need to make sure that it is regulated. It is giving all the good information thing. Next slide, please. So the challenge is, again, once again, like everybody says, not having a right devices, like a teeny tiny phone, trying to do the like a telemedicine thing, or somebody told there the patient is not able to just even do the like a Zoom call or Viber call or something like that. And yes,
Anil,
very true.
Dr. Anil, you might need to wrap up.
Okay, sorry, Dr. Buddy. Yeah, I'm gonna just take 1 more minute. So, again, it has to be user friendly. The patient need to, be, using very nicely. And then, of course, the, a doctor need to, the software need to be user friendly for the doctors. Next slide, please. Only possible in telemedicine, you guys already seen that. You can have a lot of the family members and everything you can bring into the, telemedicine thing, and you can assess the living condition of the patient in a different part. And that's only possible in telemedicine thing. Next slide. And the last part, again, with the rapid growth, I call it a digital proficiency. These new generation people are very good on digital thing. They will do really better on telemedicine. We are learning. So there's definitely more convenient way to do, more access to healthcare. I always, tell everybody, think about right device, right software, right platform, right connection, right environment, and right manner. that will take you a long way for your telemedicine. And try to work the best whatever you have available. We may not have everything available. You just have to work from where you have, and you grow the opportunity from there. And the last but not the least, you're losing your, do not lose your empathy or compassion. Actually, this is more necessary in a tele platform than in-person meeting. With that, I'd like to conclude and thank you. I'm sorry I went a little over the time. Thank you so much for letting me share. Thank you.
Thank you, Dr. Anil Swal. That was very nice presentation. Now we have Mr. Binod Chandra Shrestha from Nepal Telecom Authority. He is an engineer and deputy director in NTA. NTA is telecom regulator in Nepal.
Good morning and namaste to all of you who are present here and participant from remotely. Today I'm going to present on the topic improving access to healthcare service in Nepal through telecommunication infrastructure, challenges and opportunities. I'm working as a engineer and deputy director in Telecommunication Authority. It is a regulatory body of telecom sector in Nepal. And currently, I'm looking after the rural projects. Nepal, in Nepal, healthcare infrastructure are limited in rural areas due to lack of infrastructure and human resources also. Healthcare funding in Nepal is also low, and there is shortage of medical equipment as well as human resources, particularly in rural areas. And mainly healthcare workers are focused on urban, and people from rural area cannot get good healthcare service. And telecommunication is only the which support to get a healthcare service in remote area from the experts in urban as well as in from the abroad also. It enables remote consultation, diagnosis and treatment using the technologies through telecommunication infrastructure, basically connectivity, internet, telephones, like this. In Nepal, we in 2076 BS, Nepal government issued Digital Nepal framework, and in this Digital Nepal framework, there are 8 sectors which covers the overall digital sectors, and one of the important pillar is health in that Digital Nepal framework. And Digital Nepal framework has 7 initiatives. Seven initiatives, and Nepal government is working on that initiatives, and this is also the time to review some initiatives too, and health as a pillar of Digital Nepal framework is for addressing the issues related to access, affordability, and quality of healthcare through the digital system to the Nepalese citizen. And telecommunication sector and domain of information and communication technology is working on digital foundation, and other 7 sectors are overlay over the digital foundation. Talking about the status of telecommunication infrastructure in Nepal, currently there are 5 active telecom licenses in Nepal, and only 3 are working. They are Nepal Telecom, NC Line Smart. Rest are not working in the market. And there are 22 active network service provider licenses and 140 internet service provider licenses. For the coverage of mobile network coverage, Nepal has mobile network coverage of over 90%, and almost 36.3 million mobile phone subscribers are here. And in penetration terms, 124.45% of total population is using mobile phones. That is due to 2 or 3 mobile phones used by a single person. That's why 124.45% came. However, the quality of mobile network varies widely depending on the locations, because in the rural area there are lack of infrastructures, towers, optical fiber network, and connectivity itself, and they are not getting reliable mobile coverage still. And in terms of internet penetration, still Nepal has low penetration of fixed broadband internet. That is almost 36.75%. And talking about the mobile broadband penetration, 94.25% is using mobile broadband in Nepal. This is the status of market shares is fixed telephony service, mobile telephony service, and others. and market shares as per the by the telephone operators, that is licensee. And two operators are major operator in Nepal, NDCL and NCL. And market share of broadband is mobile broadband is mobile broadband is 74. Mobile broadband is higher and fixed broadband is lower. And operator wise, ISPs, different ISPs. In my previous slide, I talked about 140 ISPs are working in Nepal, and they provide fixed broadband as well as wireless broadband in Nepal. And rural telecommunication development, it is USO, Universal Service Obligation Fund, and it is received from the licensee of telecommunication services in Nepal, and in globally it is called Universal Service Obligation Fund. It is for fulfill the gap between rural people and urban people to use telecommunication service, and that is to minimize the digital gap between urban and rural area. And this fund is basically in Nepal used for remote areas, and it is established from the Telecommunication Act, and each service provider shall contribute 2% of their annual gross revenue to this fund. And Nepal Telecommunication Authority is looking after that fund, and currently through the grant, different telecom service provider as well as internet service provider are working using that fund based on the competitive basis. And currently information superhighway in mid-hill highway, broadband connectivity to all over the country is using that fund, and NT is planning to build national microwave backbone network to serve where the poor telecom mobile network and no connectivity. Information superhighway project that is along the mid-hill highway, connecting all the district headquarters and adjacent municipalities. There are in mid-hill highway, there is 96 core of there is low digital literacy among the healthcare as well as use healthcare through the type is used for telemedicine in Patan Hospital. Now it is used as hotline service in Department of Health for the COVID-19 related matters. And I already talked 4,249 community health centers, including health posts. Hospitals are connected through the broadband internet, and pilot projects for telemedicine in some rural area and online OPD ticketing system will be started in this fiscal year from the NTA. In my conclusion, telecommunication is foundation for any digital service, including digital health. Healthcare service can be available at the fingertip using telecommunications. Digital health is one of the important cross-cutting verticals of telecommunications. Even in 5G, it shall be considered as cross-cutting verticals. And there is equally opportunity and challenges in healthcare services in using telecommunications. By providing the access to healthcare services, medical education, information, telecommunication can help to bridge the gap between urban and rural healthcare services. Thank you.
Thank you, Vinod, sir. We'll take up questions and later on after the session. Now we have Dr. Amrit Bogati from Sahit Gangalal Hospital. His title is Hub and Spoke Model for his STEMI in Bagmati Pradesh. He's the consultant cardiologist and intervention cardiologist in Sahit Gangalal National Heart Center.
To have more discussions, we'd like to have you stay on line.
Good morning, respected chairpersons, my seniors and my friends. So today I'm going to be to deal with the topic of my presentation is how I spoke model of ST-elevation MI management in Bagmati Pradesh. That what we are doing in Bagmati Pradesh that will be discussed. First of all, we all know that ST-elevation myocardial infarction, which is known as heart attack, is a dreadful condition. So ST-elevation MI is a subset of acute coronary syndrome that requires immediate and optimal reperfusion therapy to reduce the morbidity and mortality. And reperfusion achieved within the 12 hours of the onset of symptoms, and preferably within the first few hours, result in a maximal benefit. And the burden of cardiovascular disease, as we all know, in general, and acute ST-elevation MI in particular, is increasing at an unprecedented rate in low middle income countries like ours. So For the reperfusion of the ST elevation myocardial infarction, we have primary percutaneous coronary interventions, fibrinolytic therapies, and the combination of both pharmacoinvasive percutaneous coronary interventions. So as all the guidelines have already recommended that primary BCI is better than fibrinolysis as a fibrinolytic agents. But in countries like ours, even now, fibrinolysis is more important because most of the hospitals in our center, in our part of world, they have no cath lab facility, and there are no manpower who can perform percutaneous coronary interventions. So what is the options for the patients who present with a ST elevation MI and they present in a non-PCI capable hospital, suppose in a local hospital. So for those patients, if they can be transferred in a time, in time, then a transfer for the primary PCI to a hub hospital or to a hospital where PCI can be done is better than just to a pharmacoinvasive. That is, just first give a thrombolysis, then transfer the patient to the main hospital for the PCI, subsequent angioplasties or coronary interventions, or just do a fibrinolysis therapy there and wait and watch for the patients, how they behave, and decide accordingly. So for this pharmacoinvasive strategy, it can be useful when primary PCI cannot be done within 2 hours of the first medical contact, or if fibrinolysis can be given more than 60 minutes earlier than primary PCI, regardless of whether the patient is located in an urban or in a rural area. So obviously pharmacoinvasive strategy, it involves both fibrinolysis and followed by a plant angiography within 3 to 24 hours. Again, many trials already have shown that fibrinolysis, if done in early hours of ST elevation MI, they have better prognosis. And again, for the pharmacoinvasive strategy, STREAM and STEP AMI studies have already reported very good results, and it is a very applicable strategy to reduce the mortality and morbidity for ST elevation MI patients. And when this pharmacoinvasive strategy, it basically involves that when a patient presence in a PCI capable hospital within the PCI capable hospital, so the patient will be shifted to cath lab for the primary PCI, and the primary PCI should be done within the less than 90 minutes of time. So when a patient presents in a non-PCI capable hospital, so the patient will be thrombolyzed with the fibrinolytic agents within the 30 minutes of presentation, and the patient will be transferred to a hospital where the PCI can be done within the 3 to 24 hours. So this is the same. So in Nepal, true incidence of ST elevation MI is still unknown. There are no data that can exactly predict what is the prevalence and incidence. So based on the Syed Indira National Heart Center annual reports, there has been a significant increase in STEMI patients in recent days. And also, most of the patients, about 62% of the acute coronary syndrome patients has been admitted in Tongalal, and only 27.5% have received reperfusion therapy, either pharmacological or interventional. So the main reason is that the failure of the patients to reach in the hospital within the 12 hours of time. So in Nepal, the prevalence of STEMI is rising exponentially, and despite advancement in reperfusion therapy from both pharmacological and interventional, the overall utilization, system of care, and timely reperfusion remains suboptimal in our country. So what are the challenges of STEMI system of care in Nepal? The lack of awareness, lack of transfer facilities, unavailability of hospital with PCI facilities, financial conditions, consent problem, and education for the for the general practitioners and medical officers who are working in the local hospitals. And we all know that PCI is again the gold standard, but still most of the patients, they cannot get it. So obviously ST elevation MI is very important because time is myocardium. So for each delayed myocardium is going to be die. So for these things, thrombolysis can be done in a local hospital, and then the patient can be transferred. So why I am referring this model, what we are doing is we are just implementing a hub and spoke model. So hub hospital refers to a hospital that can who has no PCI capacity, but they can perform through centers for the primary. So in Bagmati province, there are 13 district hospitals which act as spoke hospitals, and Syed Gangala National Heart Center for now acts as a hub hospital. So district hospitals within 30 minutes of the distance to Syed Gangala National Heart Center, they will directly refer the STEMI patients for primary PCI, and other hospital will provide thrombolysis with tenecteplase at the presentation, and the patient is referred to our center for the subsequent coronary intervention within 3 to 24 hours of time. So how we are doing this? So the patient will land in a local hospital, in a district hospital, and ECG is done there. And ECG, after the ECG is being done there, and they will send the ECG in a Viber group. So I think in our Viber group, we have more than 250 doctors all over the country, not only of the Bhagmati Pradesh. And after that, after the ECG is sent in a Viber group, so cardiologists from Syed Gangala National Heart Center, we will interpret the ECGs. And if the ECG shows ST elevation MI, and if the patient has having chest pain within 12 hours of time, then if the patient can be transferred within 120 minutes, for primary PCI, they are asked to transfer them to Syed Gangala National Heart Center. And if patient cannot reach to our center for primary PCI within 120 minutes, then we will ask them to thrombolyze the patients then and there. And after the patient is stable, we will ask them to transfer the patient. Or if the patient gets deteriorate of maybe thrombolysis, it cannot be successful sometimes. So if there is a failed thrombolysis, they will transfer the patient immediately. Or if the patient gets better, they can just delay the procedure transfer, and then they will transfer it later. So moving on a few cases. So this is our Viber group, actually, we can see here. So a gentleman, 60 years male, known case of hypertension with complaint of chest pain. He presented in a hospital, and the ECG was done. They sent this ECG in our Viber group. So the ECG shows an anterior ST elevation patient. So we asked the patient, who is the patient, location of the patient, and he was in Sarikot Hospital. So Sarikot is a bit far from here. So after that, we asked them to give TNK, tenecteplase, and the patient was thrombolyzed. So after ECG they did after 30 minutes of the thrombolysis, still there is a persistent ST elevation, and a patient was having chest pain. So we asked them to transfer the patient immediately. The patient was highly rescued. At the emergency of our center, patient developed VF. Luckily, VF was reverted with a DC shock, and patient was shifted to cath lab. In the cath lab, we did an angiogram, and we saw there was a lesion in 100% lesion in LAD. And after subsequent PCI, and after subsequent PCI, he had a good result. He had a TIMI-3 flow, and patient was chest pain free. So this was the next day. The post significant ST segment resolution, and the patient was discharged after the 5-day hospital stay. So this is what is being done, and this is the second case. And again, a patient presented in a Bhaktapur hospital with the inferior ST elevation MI, actually inferior posterior wall ST elevation. So he was in Bhaktapur hospital. So we asked directly to transfer the patient to our center for the primary PCI after giving the loading dose of aspirin, clopidogrel, and statin. So, and this third case is a gentleman. He was Sinduli Hospital, and there was a slight ST elevation in inferior leads. We asked them to give the thrombolysis, and the patient, after thrombolysis, there was a successful reperfusion, and there was a subsequent, there was a significant ECG betterment in ST segment resolution in post-thrombolysis ECG. And after, when he reached Syed Gangala National Heart Center, we did an angiogram. There was just a minor plaque in a left anterior descending artery, and there was barely any lesion in a right coronary artery. So yeah, we didn't have to stent this patient, and he was discharged on the 3rd day of hospital admission. So these things are being done because with the help of the Viber group, and when a patient lands in a local hospital in a remote area, ECG is done, and we are looking the ECG from here, and we are guiding them what to do. So not only ST, even for other arrhythmias. For example, in a Sinduli hospital, again Sinduli hospital, they had a patient with ventricular tachycardia. They sent the ECG, and there was no BP in the patient, so he was hemodynamically compromised. So ideally, DC shock should have been given, but there was no DC shock. So after that, they searched there, and they took, I think, half an hour to find a DC defibrillator and give a DC shock. Luckily, patient was doing well within that frame of time. And then I think their DC shock was first time in that hospital. So maybe next time they will be prepared for these scenarios in beforehand. So again, when a patient, because we are doing a lot of cardiac surgeries in hospital, in National Center. So after for the follow-up of these patients, for example, for the valve replacement and other cardiac surgery, when they land in a remote areas or remote hospital, the local doctors, maybe medical officers or general practitioners, they can just send the information and we can communicate them. We can ask them to keep the INRs in these range for the selected patients, and also for the management of cardiac emergencies. For example, I have one story that when I was returning from Surkhet to Nepalganj, I had to catch flight from Nepalganj to Kathmandu at 7 o'clock. And at about 5 o'clock, I got a Viber message, and it was from Dolpa. So it's not included in our Bagmati Pradesh. He still, he had some issues, so he messaged me. And when I was traveling, so I was chatting with him in Viber. And there was a young lady, 20 years of female. She had second day of postpartum, and she had a shortness of breath. Saturation was not maintaining, and her BP was higher side. So after that, I asked him to rule out pulmonary edema or pulmonary embolism. That's what we were concerned at that time. So I asked him to do an X-ray, because the other investigators they don't have echo and other D-dimer and other tests. So I asked him to do X-ray, and X-ray was showed some features of heart failure. So I thought it should be a peripartum cardiomyopathy with low EF, and patient is in pulmonary edema. So after that, I asked them to give nitroglycerin, injection nitroglycerin, but that was not available at that time in that hospital in Dolpa. So I asked them to give morphine and diuretics. Just I think for that whole night, they gave her 200 mg of IV Lasix. And in the morning, he called me and saw we were successful at that. We just heli rescued her to a Surkhet hospital, and at least she met that night. And that was a very good success story for those doctors who are working there, and they have done. They actually, with the limited source, they are doing a great job. And about our hub and spoke model, so in collaboration with Bagmati Pradesh, this hub and spoke model has been started from last 2 years, and we are in the initial stage, and we are obviously working for the betterment of this program. And financial support is being provided by the Bagmati provincial government, and the program includes the training of the medical personnel of the district hospitals and free distribution of the thrombolytic agents. For now, it is 10 active place, and free PCA for the patients enrolled in this program is being performed at Syed Gangalan National Heart Center. So what is still lacking? Transfer delay. Obviously, when a patient has a thrombolysis, which is heli rescues, and lack of medical personnel who will with the patient, they will be transferring the patient with them. There is no any paramedics in the ambulance, and there is no defibrillator in the ambulance. There are no other emergency medicines available in the ambulance. So these are the lacking parts, and obviously dedicated personnel to contribute, coordinate this sort of patients to this group of patients. And obviously, it's difficult to differentiate for the successful and failed thrombolysis, which patient needs early referral and which patient can we wait. So for the local hospital doctors, it will be a bit of a challenging thing. And data entry and audit, obviously, follow-up of the patients regarding the medical compliance, and obviously cardiac rehab after the discharge of the patients. And what can be done is public awareness. The most important thing is the public awareness about the symptoms and the benefit of the early treatment for the ST elevation MI patients, and education to the medical personnel for the early initiation of the medical treatments, and incorporating the ambulance services with emergency medicines and defibrillators, follow-up of the post-discharge patients via telemedicine or phone, and health insurance, if they could cover all the medicines for the post-MI patients, I think that will be nice. And bypassing non-PCI capable hospital for the high-risk patients. So if the patient is in a cardiogenic shock, or if a patient is in pulmonary edema, they should be referred for the primary PCI rather than for the thrombolysis. So to conclude, hub and spoke model in Nepal seems to be feasible for early diagnosis and management of STLS and MI management, and pharmacoinvasive strategy is applicable in our settings. This is just initiation with one province, with one hub hospital, and with one source of telemedicine. That is only Viber group. I think we can increase the. We can use other platforms, and then most of the patients and doctors of the local hospitals, they will be benefited. And obviously government support, people awareness, dedicated medical personnel can make this project a huge success, and hand in hand with other hospitals as well will help in reducing morbidity and mortality of STEMI patients in Nepal. Thank you. Thank you very much.
Thank you. Thank you, Dr. Amrit Bogati. You had a very nice presentation. I think hub and spoke model in Nepal must be thought for all digital health initiatives, not just for STEMI patients. We have the last speaker of the session, Mr. Kabin Maliku from Ask Foundation. His title is Establishment of Rapid Phone Consultation Service for COVID-19 Public Health Support in Nepal. He is operational manager in Dafe Care on behalf of Ask Foundation.
Namaste everyone and very good morning, and good morning chairperson. My name is Kabin Maliku and I am representing Ask Foundation right now. So it's been quite late to discuss about the COVID, but like I feel like it has to be shared what we have experienced during the COVID. So this is the establishment of rapid phone consultation services for COVID-19 for public health support in Nepal. So as you know, like the COVID cases was surging very high, and this was during the second wave. So we were doing the COVID consultation through the Dafe, and all of our colleagues were very much occupied due to like huge phone calls in our personal numbers. So back then in 2020-21, so there was like a group of organizations who has been actively participating in so they approached us and we formed an alliance called COVID Alliance. So so they like we had a sort of the discussion like what we can do to solve the crisis. So all of a sudden, like from our side, we had a two agenda. One was vaccine, and next was the medical hotline to solve the like various health queries. So this is how it started, and we had no any plans and no any fundings. And the team just asked like how much funds you need, and I was just said like 5 lakhs rupee for a month of operation. So it's like okay, then let's start, right? And it took like 5 days of planning time, and we started in the 5th day. So that's how the medical hotline started, and I'm just going to share how we started it. So well, establishing a hotline, we were expecting a dedicated number, and we explored the NTC and SmartTel. And SmartTel company was more coordinating, and they provided us very easy number. And with the SIP line, so the SIP line is like session initiation protocol, where with a single number, a number of calls can be handled. And like that SIP line was like in a single line, you can handle 10 to 30 phone calls at the same moment. So we took the SIP line from SmartTel, and a very unique and easy number, 10-digit number. And we approached a Voxcro company, which has been supporting various banks, various other big organizations to provide such kind of services, phone line service. And they had a software called GetDex. And we distributed the calls to the GetDex. We established the VPN line in each agents. We call our health professionals as agents. And our health professionals have been working from their home, from their laptop. And we set up the software, and the SIP line, the mobile number was with the Voxcro. So that is how we started. And we used the Danfe Care as like all the technology support, everything. So we pushed a vacancy notice, and some of the interested doctors and nurses, they came us, we hired them, and we provided a structured training. So the training included the clinical management training, which was totally based on CDC guideline and NMC guideline. Apart from that, we categorized the diseases as per the NMC, and we followed the phone triaging model of CDC. And we also developed like a algorithm-based questionnaire, but we didn't make it much better because it was taking like 15 to 20 minutes of time while implementing that questionnaire. So we structured our own questionnaire, and we provided training for our clinical team. Then next one was the communication training from our communication expert. So she trained our team how we can communicate with a phone call, right? So so there was a structured communication like questionnaire, so that the caller can feel very easy to call our while communicating with our healthcare professionals. And next one was operational training, which was all about the software, how we can operate. So it was done by the healthcare management expert. It includes me and the next one of my colleague. So we had a like mock drill on the 5th day, and we started on the 5th day. Like it took just 5 days of planning, processing, and implementation of such hotline. So the main idea of initiating such hotline was to increase the accessibility of the consultation among the general public, so that like we had already structured software, already appointment system, everything, but it was not that easy when the COVID was surging very high, and like the cases per day was like 3,000, 4,000, 5,000. So I thought like, why not we, like mobile phone is in everyone's hand, and why not we start it? So after that, we realized that nearly 70 to 80% of smartphone users have Fiverr in their mobile. So Fiverr was the next option while sharing the prescription and advice in a written form. So during the implementation, we focused on this area. So we had a dedicated team, dedicated time hours, and sufficient time for the callers. Like we didn't hurry, like we didn't like concluded our communication. We provided as much as time, like whatever they had. Like then like later on, we thought that we started with telemedicine system, but we realized that we are getting a lot of queries, and we felt that we are serving as a telehealth support through our phone calls. And we have some data So we captured the information from the GateDex software of like our company, Nepali company, and then whatever the data has been done, we reflected it from Google Data Studios, and also all this system process has been supported by IT engineer. So within 5 days of time, like it was very short time, and awareness regarding the phone call was very difficult. So we used all the platforms, all the possible media to circulate the phone numbers. So we used offline medias, online medias, we used social medias, Facebook, TikTok, Instagram. We asked the social media influencer to share our phone numbers, and we asked the PCR lab to put the numbers on their where the PCR is being done. And we also asked some of the organizations to distribute, delivery organization to distribute the flyers and everything in the local areas. So this was the first team who dedicatedly started. Dr. Isani is with me, and Santosh Pradhan, he's an IT guy, and he worked very hard to make sure that the whole process goes in very smooth way. And every day we used to have a discussion, and during the first initial days, we used to get lots of queries, like let's say where you can find the ICU, where you can find the ambulance, where you can find the oxygens, right? So after that, after realizing the queries, we started adding up the information in our system, the GetDex system, and so that our callers, our healthcare professionals can answer the calls. So these are different queries which we segregated. So we thought first to answer the calls for the COVID clinical manifestation, but later on we realized there are lots of queries. So we started adding up the information. So these were breakdowns of the inquiries we received during our calls. So these are the total calls during our eight month of period, 12,555 calls. Some of the calls we missed, and later on, whatever the calls we missed, we used to call them back. And we used to flag any of the critical case, and we used to follow up the next day. And we even asked the callers, if you don't have any phone balance, you can just give us a missed call and we'll respond it back. So this is the data of the call volume. And so that's how we structure our timeline. So we started from the 6 a.m. to 9:30 p.m. So most of the calls we used to get at the morning, 8, 9, and 10. So we received the phone calls from more than 50 districts, and this is the distribution chart. That is the gender distribution chart. And we are surprised, many of the people has been using social media, and we are getting the calls from very remote parts of the country. And most of the calls we received from the Kathmandu Valley. This is the patient age distribution chart. So we received from the maximum calls from between 20 to 50 years. So I just want to answer your queries. So some of the calls we received for the pediatricians, right? For pediatricians. So we had let me answer this. So we had a pediatrician dedicated for the hotline. So at the beginning, we thought our medical officer and nurses will be able to answer all the calls. But when we felt there are lots of pediatric cases with the COVID, we asked Dr. Smriti to join our team, and she dedicated her time every day. So we started getting the calls for the kids as well. So these are the outcomes after our work. The healthcare worker were just a click away. We addressed the physical health, mental health, and social issues. The social issues used to be I'm being infected with the COVID and I'm in a rented house. So how can I adjust with my my tenants or my other people who are in the same house? So these kind of issues we have been suffering, and our team members used to answer such kind of queries. It used to be a single point information before we started the phone consultation hotline. We thought that it will be just a phone consultation. Later we started getting the a request for a lot of things, so it became a point of information for other information. we had a dedicated pediatricians. We thought that we should have the experts from consultants from other disciplines as well, but we couldn't do it. And the process, the questionnaire was drafted in such a way that we had a very in a very proper triaging system, so that like we can refer the callers in the timely. So we had some limitations. So as I told you that to increase the accessibility, we had made a phone call system. So it was just a phone call system. There was no video call. So it was just an audio call system. Next one was like the calls were charged because like we are very hurry, and we thought that the people won't they won't hesitate to call even if it is charged. And the problem with the toll free is like when we establish a toll free number with the NTC, the NCL user can't call in the free number with the NTC. And when you are calling from NTC, then the NCL number, the NCL toll free number won't work. And even you should have a minimum balance to have you can make, if you should have a minimum balance to make a toll free call, right? So those are the challenges we're still facing right now. And we had a limited time. We thought to start like around like 24/7 services, but we had a very limited team, and like with like 200, 300 calls each day, and our team has been exhausted. So we had very limited time of like 15 to 16 hours. So we had a lack of full-time consultants and funding, of course. So we thought to start, so we thought to run for 1 month. And interestingly, like we got approached from Canada embassy, Canadian aides from Delhi, and they approached us and they asked us like, you hotline, and we continued our hotline for 8 months. These are the lessons we learned. Like this kind of hotline, medical hotline, can be used for information center for other health informations, maybe ambulance or blood or hospitals or medicines or oxygens. Case follow-ups can be done. If we are doing the multidisciplinary approach, yes, obviously we can succeed. We need a dedicated team. If we don't have a dedicated team, we can't expect a good result, right? So, and the next thing, like we have trained our healthcare professionals. Like we can't expect everything, right? So they has to be trained, updated. We expect like our healthcare professionals is expert in everything, but we should train them about the software, how we can operate efficiently, how we should communicate. So how we can communicate. So these are things we need to train. We need to have a and ready-made protocols in place and SOPs as well. Like whenever such pandemic or epidemic happens, or even the natural disaster happens, like we can implement the things instantly. And the collaboration, of course, like we should have a collaboration of private and government bodies, and even there might be other individuals which might be interested and who might be like expert in this area. So we should not hesitate to collaborate with different organizations. So these are my recommendations for all the stakeholders. Medical hotlines should be readily available. It should be able, like it should be a center for all the health information. It should be under the government body. It should be dedicated for pandemic, epidemic, and natural disasters. And all the protocols, SOPs for functioning of such hotlines should be in place. Whether it is for maybe next time we may need for the dengue, or maybe for other influenza or swine flu. So we should have the protocols and SOPs for telemedicine in place for such kind of case. We should have a multidisciplinary approach, and multi-sectoral collaboration is much needed. Thank you so much.
Thank you very much for keeping time. Exactly. Thank you, all the speakers. Wonderful presentations. We are already working in Nepali time. That means the time has already gone a long time back. So we'd like to, we talked about telemedicine culture. I think we should have a culture of our system time also, because we sometimes when doing telemedicine, we are talking about time zones, and some people may be sleeping at night and you need to have time. So, but we'll try to give you at least 1, 2, 3 questions, short questions, short answers. If anybody has any questions to anybody, any speakers out there. Yes, sir, please. Could have short questions, short answers, so that save time and good experience. Please give the mic, please. Sir, please. And yeah, what?
Okay, Good morning, everyone. I am Dr. Dheeraj Jaswal, working as a clinical coordinator in Battery Hospital. I want to ask Dr. Amrit Bogati. It was very nice presentation, and I was facing this problem very much. As you know, when we refer patients of ST elevation from Baitari, it took almost more than 12 hours to reach the patient to Nepalganj, and most of the time patients doesn't want to go there, and we don't have these fibrinolytic medications as well. So we are still depending on the pharmacological methods. So my query is, can we be added to this project, or can we reach you by some way? Thank you.
I have already mentioned that in our Bible group, there are more than 250 doctors, and they are from all over Nepal. It's not just the Bagmati Pradesh, and you are welcome in our Bible group. So if you have any queries, or if we can help anything, but for specifically for the Bagmati Pradesh, we are providing the 10 active place, at least 2 at a time, with the free of cost for these hospitals. 13 district hospitals we are providing. But for other than the Bagmati Pradesh, I cannot assure you that I can give you these medicines, because it's not in my limitations. So actually, but for the betterment of the patients, and if you have any queries regarding the cardiology part, especially the acute cardiac emergencies, you can be added to that group, and I think we will try to help you what we can do.
Very interesting question. You can have the money for the medicine, but they will support you with all the things.
Sir, can I have the Bible number?
Yeah, I will add you later. Okay.
Okay. Anybody else? Yes, ma'am. Please. Please.
A nice presentation. I'm Kuriko Kudo from Telemedicine from Japan. I have question to the person of Nepal Telecom Authority, Engineer Binodo, and Sang, and very interesting the plan for the networking. And I am especially surprised that in Nepal the mobile percentage is 124. And I searched in the Japan case, it was 96% in Japan. So yeah, really the mobile network is used in Nepal. And as you explained, the information highway, super highway, this plan. And is this mainly for the wireless, or you also doing the wired one? Yeah. And I also see many wired is in the town in Nepal, so I just worry about if that weather is bad and the connection is not bad, or this kind of problem will be happen. So please, give me your opinion.
Thank you for questions. The penetration of mobile is due to subscription of more than one number by single user. And we consider the number of subscription of SIM cards from the operator. That's why the penetration is more than 100%. And actually, the number of persons using mobile phone is below the 100%, because children and elder people, some elder people may not use the mobile phones, but that number is came from the subscription of SIM card from the operators. And your another question is regarding information superhighway
projects.
That is operated using the USA fund. In Nepal, it's called Rural Telecommunication Development Fund. That is contributed from the licenses, that is telecom, ISPs, NSP, everyone. And that fund is utilized for the information superhighway project, and it built a optical fiber network along the mid-hill highway and connect the district headquarters as well as adjacent municipalities of mid-hill. And then it will create a backbone network for the Nepal, and the licenses for the service internet service provider, that is ISP, can get backhaul through that particular backbone network, and there will be sharing of infrastructure for providing the internet connectivity as well as telecommunication to the people. And progress is not satisfied till date, because due to some work is postponed due to pandemic situation, that is COVID-19, and most of the equipments as well as material shall be come from abroad, and the operator could not bring the materials, and timely they could not complete the work.
Okay, thank you very much for your nice.
Thank you very much.
explanation.
I think one more last question, because we have a tea session where we can communicate and network again. Thank you.
Thank you, Binodji. I have just few questions, and also I have some suggestion. Can I also? Okay. For RTDF fund, have you already invested some amount for this digital health, or you are just planning? Is there any budget allocated already?
In this fiscal year, we plan some pilot project for telemedicine, as well as the development of online OPD ticketing for some government hospital or community hospital.
And
this year.
what is the bandwidth that you are providing for the health infrastructure?
Bandwidth
currently, the hospitals and all those health posts that you have already connected.
Yeah, previously the health centers, I talked in my slides, 4,200. These were connected broadband connectivity of 1 Mbps internet at that time, and now we are providing 15 Mbps connectivity to.
Okay, thank you very much. And one more interesting thing, like Dr. Amrit has presented on the hub and spoke. I just have some suggestions, like it's a very interesting, and it's very, I mean, I think it's very, very important. I just have a suggestion for NTA, and I think we can work together. I'm from NREN. It seems that it's a very interesting, and it can be used efficiently if we go to the NREN network infrastructure, because you are using the fiber. No, that's very good for now, but there are many other options. Like for if we can work like NTA and Gangalal Hospital and NREN, maybe with coordination from the Telemedicine Society, we can do a lot, and it's very, very efficient that we can go to our NREN network, which will be localized, so bandwidth will be very high, and we can use this ECG, digital ECG things, so we can get the live information. So why don't we work together to create that infrastructure? And if we are focusing on Bagmati, it's for NREN network is already in most of the part of the Bagmati, so we can work together on that. So that is only my suggestions, and it's a very interesting. I didn't know that this kind of information system exists. Thank you very much.
Thank you very much. I think because of the tea, you'll have a networking time. Last question. Last question, sir. Because Nepali time is also gone now.
Thank you, sir. Thank you, sir. Yeah, my query is related to the Binu, sir. Yeah, actually, I am just curious about the investments that has been doing through the RTDF fund. So my questions is related to the usage of the fiber backbone. So is it just for the providers, or other RNA community can be able to use those fibers? Is there any such kind of policies with governments?
As per the current legislative provision of NTA for providing the telecommunication service and internet service, that can be obtained from only the licensed service provider, and anyone can get the service from that service provider, and service provider is providing their service through the backbones as well as distribution network created through the RDF fund, and who are not working for the RTDF fund also can use that network by sharing best, and the service provider who worked with that RTDF fund shall provide on the regulated tariff to the other operators, and anyone can get the service through them. Even if they need dedicated core or lambda sharing or any bandwidth sharing can be obtained from them. Thank you.
Okay, so it means that if the government want to use their fiber, so in that case as also we don't have such provisions, so they need to pay for the providers in that case as well?
Yes, there is operation cost, maintenance cost shall be there. That's why tariff is regulated tariff. As per the regulated tariff, the operators shall be paid. And in our project, some portion of the fibers are allocated for the government use also.
Okay, so yes, thank you. Actually, I heard about the 70 and 30 related policies. So 70% of the usage will be the private providers, and 30% will be blocked for the governments and other services. Maybe that is not the case.
Yeah. In case of fiber, that is true. 25% of the core shall be provided to the government.
Okay.
Thank you very much, Mr. I think the tea is getting cold, so it's not that happen. First of all, let me thank Mr. Pavan Sakya for co-chairing this. Thanks all the participants presentations. I learned so much things out there. Anil from USS, thank you very much for presenting, and all the participants for actively listening and even participating. Thank you very much, and we hope to have a tea, and you can always network and find out people and discuss things. Thank you very much.
Thank you, Professor Vaidya and Mr. Sakya. We'll have a very small break only, since we are already running late, maybe 5 minutes. Maybe you can get your tea and join from the table also. So we'll be back soon.
Your schedule on Saturday, post launch always session त्यसपछि अनि पछि छ थर्ड सेसन चाहिँ लन्च पछाडि ल ठिक छ यो उसबाटै हो
राम्रो सर हुनुहुन्छ राम्रो प्रसाद और email. Info our TMS. Info active. Info at TMS that what it is. That what it is. That what it is. That what it is. Yes, English is no, no. That one.
This. Hello, let me check the remote participant. Ueda-san, are you there? Hello.
Can you hear me?
Yeah, I can hear you. Thank you.
Thank you.
And the Dr. Khan is there? Maybe no. Maybe no. And Mr. Satya, AIG?
Can you hear me?
Yes, I can hear
Yeah,
you.
good morning, Ms. Burko-san.
Good morning. Thank you.
Thank you.
Joining. Okay, then Mr. Zahir from the University of Malaya.
Hello, hi, good afternoon, good morning.
Hi, Zahir. Thank you very much for your joining today.
All right, welcome.
Okay. Then maybe no Tungu. Is there Tungu? No Tungu. Okay. Then the Dr. Dimple. Are you there? Dr. Dimple? She is still not joined yet. And Hisada-san?
Yes, I'm here.
Okay. Okay, that's all our. Okay, there's still we have the tea break, so please wait for a while. The session will start soon.
Okay, sure.
Oh, hello, Tai-san from the Vietnam. We can't hear you, but.
Hello, can you hear me?
Oh, yes, hi. We can hear
Yeah,
you.
hello.
Thank you.
Yeah.
Thank you
Thank
joining.
you.
And Zora-san, are you there from Mongol?
Hi, I'm
Hello.
here. Hello, how are you?
Yeah, I'm good. Thank you. Maybe you cannot make presentation today.
Yes, I
Okay,
just joined.
okay. But thank you very much participating while you are busy.
Welcome.
Is there Dr. Dimple from India?
Okay, my dear. I'll start the session.
Welcome back, everyone. So we are going to start our second session, which will be a telemedicine engineering workshop. So for this session, our two chairpersons are Dr. Rajan Parazuli. He is the director of ANREN, and Mrs. Kuriko Kudo, who is the vice director of TEMDEC at Kyushu University. So I'll request the chairperson to start the session.
So thank you very much, ladies and gentlemen. I'm very happy to start the session 2, telemedicine engineering workshop. In this session, we will discuss the recent digital devices and the different opportunities and challenges faced by engineers in telemedicine and digital health. And we have many Asian presenters from the international countries, and we will have 6 presentation planned. And after that, we will have the question and discussion session. So let me introduce first presenter. He is Dr. Shintaro Ueda, a PhD from the Kyushu University Hospital. Title is Report on International Telemedicine Training Program. He is doing some training program with targeting the developing countries. So let's please start presentation.
Thank you, Kuriko, for introducing me. I'm Shintaro Ueda at Telemedicine Development Center of Asia, TEMDEC, Kyushu University Hospital. And today I will talk about training we at TEMDEC carry out for overseas telemedicine engineers. This Sakura Science Exchange Program is supported by a grant from the Japan Science and Technology Agency. I would like to start with the outline of the training program. It is very important to create and maintain a network of skilled telemedicine engineers to establish continuous international telemedicine activities. Based on this aim, we carried out a training program online in 2021 and an on-site program this year. For the online program, we discussed what the issues are in carrying out telemedicine activities and discussed what the solutions may be and got together once again to see if the engineers were able to implement the proposed solutions. For the on-site program this year, we focus on hands-on training for telemedicine engineers, how to set up live demonstrations in hybrid conference rooms, and carried out the demonstrations of new technologies. Here's the list of countries of the engineers who participated in the training program. There were 3 from Vietnam, 2 from Bhutan, 1 each from Indonesia, Nepal, India, and Malaysia. A total of 6 countries and 9 engineers. Here's the schedule of the training. Here's the schedule of the training. It was a total of 9 days if you include the arrival and departure day. Orientation was carried on the 2nd, hands-on training on the 3rd, 6th, and 8th, and culture study on the 4th and 5th. And I would like to introduce you to each day of the training. First, arrival. Everyone arrived at Fukuoka Airport on the 1st of February. Shunta and Miho took them to the hotel from the airport, and that was all for that day. The first day of training is always orientation. Orientation of the training program was carried out by Kuriko on the 2nd. The objective and schedule of the training program was introduced. On the 3rd, the engineers learned how to set up a hybrid conference room from scratch. First, a lecture was given by Yoshiko, and after that, they moved to the venue and actually set up according to the equipment diagram. This was the equipment diagram. 3 laptops were used, one for the input and output of the audio and visual data to Zoom, one to share the presentation via Zoom, one for sending the presentation slides image data, and for audio, 2 wireless microphones and a portable speaker system was used. They were connected to the laptop via the audio interface. For visual, a PTZ camera and a projector was used. This is the scene of the engineers actually carrying out the setup. The main objective was obviously hands-on training. There is a difference in understanding the equipment diagram in your head and actually being able to set up based on the diagram. So this was a very valuable experience for the trainees. On the 4th and 5th, the group visited Hiroshima as a cultural study experience. They rode the Shinkansen, the bullet train, from Hakata Station. First, they visited Hiroshima University, where they received a special lecture from Professor Yoko Shinfuku on fetal ultrasound education for midwives using information communication technology in Tanzania. They learned the challenges and success of educating overseas with the use of minimal equipment. After some sightseeing, the group experienced the different types of hands-on training. They experienced making okonomiyaki, a Japanese cuisine. After returning from Hiroshima on the 6th, the next day, they experienced a live endoscopy demonstration using 360-degree virtual reality. First, there was a lecture from Yukiko. For most, it was their first experience of virtual reality and 360-degree camera. Before moving to the endoscopy room, Yukiko showed the group the actual equipment that will be used. Here's the 360-degree camera, the virtual reality head mount display, and the audio equipment. This is the equipment diagram of the live demonstration. I will skip the explanation since Yukiko will probably explain about this in her presentation later in the session. This is the screen of the screenshot of the live demonstration of what the users saw on the laptop. This part is a 360-degree image. The user can move the image using the mouse. This is an example of the 360-degree view of the endoscopy room. The trainees learned the basics of setting up the live endoscopy demonstration and an additional tips on how to implement it to 300 degrees virtual reality. On the 7th, the group was given an explanation of a video sharing platform called JoinView. After the demonstration, there was a discussion on how this system can be used for educational purposes. Also on the 7th, Indonesian trainee, Nopa, carried out the 33rd Indonesian Neurology teleconference from the TIMDEC conference room. At TEMDEC, we always have the trainees carry out a training report conference at the end of the training. There are two aims. One is to set up the venue used for the teleconference. Another is to give a report about the training, what they experienced, learned, and what they will take back home to their country. On the 8th, the group carried out the training report conference connecting their own institutions and other Asian institutions. They first set up the conference room and then gave presentations. All presentations were carried out and the group were given certificate of training. This concludes the training, and this is all for the explanation. Thank you for your attention.
Thank you, Sim, for a nice presentation. So maybe the many participants or the remote participants are interested in your training experience, but please keep your questions after of this session in the Q&A session. So the next is I'd like to introduce the chief engineer from the Asian Institute of Gastroenterology from India, Mr. Satya. He explained about the activity and technical updates in AIG.
Hello, everyone. Hope you can hear me.
Yes, sure.
Yeah. Good morning and good afternoon to the people residing in other countries. First, I would like to thank Ms. Kuriko-san and Professor Moriyama and the organizers of Nepal ATS for this opportunity. And I was instructed by Ms. Kuriko-san to present on the activities what we held at our institute. So I'm going to talk about not much on the technology part, but it is only on the activities what we did at our institute. These are the activities and the technical updates from our institute. First, I would like to talk about the one major event what we did. This is the endoscopy workshop what we did to the Kansas live workshop on 11th March. This was transmitted to the US actually. And if you see, this was transmitted from Hyderabad to the Kansas city. There are around 300 people watching this technology, and everything is done using the Zoom only. So you can see the images are very clear. Our chairman, Dr. Nageshwar Reddy, is doing the procedures in the theater. And this is what we did for the, this was happened recently on 11th March. And the most important thing is we have a live pathology reporting from the endoscopy suites. You can see our pathologist is reporting from our endoscopy suites with the slides live. So this helps the clinicians to take a decision when the patient is on table. So the pathology, based on the pathology report, the clinician can decide whether it should go to the surgery or it has to be treated medically. So based on that, they go for the metallic stunting or the patient has to be referred for the surgery. So, this is the pathology reporting, the live reporting of the pathology. You can see our pathologist there reporting.
And these cells are appearing to even infiltrate the stomach fragment here. So, in fact, whenever we get such good smears, we can conclusively say that it is positive for malignancy and adenocarcinoma.
Yeah, this is how our people record, and this is the other event which we did recently on 24th and 25th of February. This is the first time in the first international workshop, I can say, in the world. It is only for the women GA endoscopists. So you can see all leading women endoscopists on the bottom from different countries. And it was the first time happened internationally. All the performers and speakers are women. It is only dedicated to the women GA endoscopists. So these are all the world's leading GA endoscopists all over the world who participated physically. Most of them are physically presented here. And this is the group picture of national and international faculty together from our, you can see our chairman also here. And these are the international faculty performing in our endoscopy suites. These are the two photographs, and at the same time, we operated 5 endoscopy suites performing the procedures. And all these 5 rooms are controlled here. This is our main control room. We can see me and Mohan. I am just behind Mohan. You can see Dr. Reddy, who is present. He is physically monitoring all the transmissions from there because he is very keen on the academic programs. This has been, this is our control room. All the 5 theaters we are controlling from the studio, and the transmission is being done to our auditorium, which is a capacity of 400 delegates in the auditorium. And at the same time, this has been transmitted to the almost to most of the European countries by different companies. And we have almost around 6,000 participants online from all over the world for this conference, because this happened on the first time. And this is the other one which we did in 4th, 5th March. This is for cardiology behind guidelines. There are so many guidelines in cardiology. This conference is basically to bring in the things beyond the guidelines, what we can do, what they are doing now. When it comes to clinical practice, sometimes we have to do something beyond the guidelines. So this was a very successful event, and this was also attended by almost around 1,800 delegates online. So most of these programs are hybrid conferences. The other one, what we did was, this is actually, in fact, it was done in association with the Olympus. So this is on surgery procedures, enhanced image guide surgeries, the future. All the future is going to be, I think Professor Moriyama sir can talk about this. This was also hybrid manner we did. And you can see these are all leading Indian surgeons who participated as speaker and performed some surgeries, and which is transmitted again to our auditorium as well as the Zoom participants. And another one is the World Kidney Day. We organized one awareness program for the patients. This is purely for the patients. We organized that kidney health for all. And the other one is, this one is the state pathology conference which held in our hospital, and there also we had the live pathology reporting in from the endoscopy suites. And here we showed the pathologist how to collect the sample first, how to take the samples endoscopically or ERCP way, and then how to mount on the slides and how to report the how quick we can report the pathology. So which helps the clinicians a lot. So this was attended. Most of the participants are the pathologists all over our state, and the people participated all over India over the Zoom. And this one is also by Olympus. We did. This is the world's first live surgery workshop. It's a 4K 3D system introduced first. You can see Mohan is helping in transmission. This studio is from the OT complex. The first one what we saw was the endoscopy suites, and this is exclusive transmission room for the OT. And the other one is retroperitoneoscopic surgery. So there are so many workshops happened during this period for the past 6 months, I can say. Those are all hybrid basis. And this one is actually, we did it for the cardiology workshop was in Bangladesh, Dhaka, and we did cardiac procedures live from our institute. You can see these 2 doctors are from our institute, and they presented, and we also did live cases from our institute. And this one is ATS skills cardiovascular course. So this is also a hybrid model. People attended in our auditorium, and at the same time, it has been transmitted all over the world for the doctors to learn. And again, this one is an upper limb trauma workshop. Here people attended physically to have the hands-on workshop, and it was transmitted again at the same time. The other one is, this one is the Omicron. When Omicron was on rise, people used to have a lot of questions, lot of issues. So whether what precautions they have to take, whether it is serious or not, when to get admitted, what medication to be taken. So this is conducted for only for the general public, and it was reached almost, it is even now the views are going up every day because it was very useful. So these are the activities we did during last 6 months. So these things I wanted to share. Technologically, there is not much, but it's the same Zoom system. But all the transmissions, most of the transmissions from our studio to the auditorium is on fiber optic basis. So the quality is in HD quality transmission. And whatever we did over the Zoom, and all the places the feedback was the excellent video quality, and shifting over the room was very simple. When we operate 5 rooms also, 4 rooms also, shifting will take hardly no difference actually. People won't notice also. We shift because of the system what we have, the digital system what we have in our transmission room. So these are the technical issues I would like to share with all of you. Thank you very much.
Thank you, Mr. Satya, for your wonderful presentation. I didn't imagine it. The number of activity were held just 6 months, last 6 months within. Really a nice presentation using the special setting of audio visual. Nice. Congratulations for your team. Thank you.
Thank you so much.
And the next presentation is Mr. Zahir from the University of Malaya, Malaysia. He is also head of technical team in University of Malaya Hospital, and also they have the telemedicine center. And he will make presentation about the activities and technical updates in Malaysia. Thank you. Hello, Mr. Zahir.
Hello, Rico. Okay.
Thank
Hang
you.
on, let me share my screen. Sorry. There's some technical issues. My presentation will be the next one. So can I
Okay. Yeah. Then please prepare during the next presenters.
Sorry.
So next presentation is from the Dr. Dimple Chopra, but is there Dr. Dimple? Maybe not yet. Okay. Maybe no Dr. Dimple. Okay, then the next speaker is Yukiko Hisada, PhD from the Kyushu University Hospital, TEMDEC. She is doing the 360-degree technology, and she transmitted the endoscopy live using 360-degree camera. So please, Hisada-san.
Thank you, Kuriko. Hello, everyone. Namaste. This is Yukiko Hisada from TEMDEC. Today, I will talk about 360 degrees live demonstration. As Shintaro talked, TEMDEC had Sakura Science Exchange program. During the program, an endoscopy live demo using 360 degrees camera was held, and I would like to report about this event. This time, most new for us in this live demo was the use of 360 degrees camera and head-mounted display. 360 degrees camera, theta V. Yes, you can take picture or record video 360 degrees around you. head-mounted display, Oculus, is the kind of display that you wear on your head, like this. By wearing Oculus, you can see all around view as if you are there. These are the pictures of endoscopy live demonstration during Sakura Science Exchange Program. "360 degrees video provide a holistic approach and therefore are supposed to show not only skills but also promote conceptual information. Although is not only effective for demonstrations but also for resident learning. The immersion and interactivity of virtual reality increase learners' motivation and understanding. Relations can be better understood by the depictions of depth via 3D imaging by using head-mounted display. The major add-ons of 360 degrees video is immersion. In this case, the feeling of being in the endoscopy room. For this live demo, I used 3 cameras, endoscope and web camera, and 360 degrees camera. This is just image of 300 degrees photo on flat display. This is our staff room and my desk. You can see my desk expanded when you see at flat display. Okay. Now I will add web camera image and endoscopy image in the 360-degree camera image by using OBS. This is picture in picture. This way, the trainee can watch not only the endoscopy, but also observe the operator's actions and interaction within the endoscopy room. In endoscopy room, this time we used gastric mucosa model. We set up web camera in front of operators so that we can see what operators are doing. Ideally, 360 degrees camera should be placed in the center, but this time I set up here because to set up in the center, I need to hang from ceiling. Endoscopy was used here with the gastric mucosa model. I put 3 camera images into one computer. Make picture-in-picture image by OBS here. I also put audios and stream to YouTube. So you can see the demo by using Oculus or of course by computer monitors. Now I will show you our live demo on YouTube. I hope you can see this. This is camera image. You can see 300 degrees around like this. This is picture-in-picture endoscopy image. And this is picture-in-picture web camera image. When you look up you can see the ceiling, and when you look down, you can see the floor. However, the place that I put web camera and endoscopy image was not good, and as you can see, it is a bit confusing. I should have put picture in picture at a better place. After the demo, the engineers and doctors were asked to fill out a questionnaire. There were 9 engineers and 2 doctors, total 11. For endoscopy image, webcam image, 360 degrees camera image, these questions were asked. Most of them answered very good or good for all questions. So it seems that this way of live demonstration is sufficient. But in my opinion, the image sharpness and movement should be improved. Conclusion. While viewing the 360 degrees videos, the user can observe the entire endoscopy room as if they were standing in the endoscopy room. If the endoscopy video is also embedded in the 360 video, the trainee can not only watch the endoscopy, but also observe the operator's actions and interactions within the endoscopy room. However, the resolution needs to be improved. Thank you.
Thank you. Thank you very much, Yukiko Ishida-san, for your very interesting presentations on 360-degree live demonstrations. So we're very happy that you have considered our network engineers from Nepal as well. So to promote good chances to have the real demonstrations. And I hope that he will be able to share his knowledge to the rest of the other engineers in Nepal as well. So moving forward, I'd like to invite Dr. Dimple Chopra from Punjab University. So her topics will be telemedicines, the Indian scenario. Over to you, Dr. Dimple.
Is there Dr. Dimple? Still not joined yet. Maybe preparing. Hello, I can see Dr. Dimple and the participant list. Can you open video and microphone?
Hello, how are you? Good morning.
Yeah, good morning. Thank you. You just joined.
Yeah.
Okay. And can you see your presentation presented from here?
Yeah. Shall I
Okay.
start?
Okay, so you can start presentation and please say next slide when you want to show the next one.
Okay. The topic of my talk is telemedicine, the Indian scenario. I am Associate Professor at Department of Pharmaceutical Sciences and Drug Research, Punjab University, Patiala. Can you show the next slide, please? Now, telemedicine, as it is known to everyone, it is use of electronic information to communicate technologies to provide and support healthcare when distance separates the participants. Next. Now, the objectives of telemedicine in India is for the rural, population, 70% of our population lives in rural area and remote areas like Himachal Pradesh. So we want the quality of medicine to be same as that a physician provides in person. And telemedicine is a very cost-effective way for developing countries. It provides access and care in case of remote areas, as I mentioned already. Now, the models in India are government operated and government funded models. These are the states, Tripura, Tamil Nadu, Maharashtra, where the government is operating the telemedicine network and they are funding it also. And this comes under the National Health Mission Scheme of India. We have public-private partnerships as well, where a private agency operates the telemedicine, but it is funded by the government. And these are the states like Rajasthan, Telangana, Himachal Pradesh, where we have public-private partnership. Now, in India, there are 12 states in which we have a telemedicine network. You can see Himachal Pradesh, you can see Punjab, where I live in Patiala, and the adjoining states, Rajasthan, Uttar Pradesh, and Himachal Pradesh, you have some remote areas where telemedicine is very, very effective. Now, we have a real-time model. Real-time model means the patient and the doctor, they have a live conversation. It is only possible when the internet connection or connectivity is very strong. That was quite successful in Rajasthan. So they have live video conferencing. Now the patients, they are layman. They don't know medical terms. So people assist them, qualified nursing assistant or paramedical staff, they help the people. In some of the states like Tripura, can you see the state over here, Tripura? A small state in a remote area. There, the connectivity is not, there are certain limitations. So what we have a store model where the data is actually stored and it is by an internet operator, it is conveyed to the specialty center. And the physician give advice to the patient. So you don't have a real-time conversation between the patient and the physician. We have specialty care like dermatology, radiology in some of the telemedicine center across 12 states in India. And we have some general care also. This is the National Health Mission funded telemedicine program in 12 states of India. Now, to my surprise, I could find that the telemedicine infrastructure is used by various states. There are additional uses they have put in. Like sometimes you have a helpline, medical helpline. So Tamil Nadu, they are using the helpline along with the telemedicine infrastructure, they have combined the both. And in Himachal Pradesh, you have some remote areas, Lahul Spiti, which is very, very remote. So there, if you want to provide some tele-emergency consultations, or you want to have some outreach services, that has been very successful. In same Rajasthan and Odisha, Rajasthan in yellow, you can see over here, neighboring state to Punjab, and green state over here, Odisha. They are also trying to use the telemedicine infrastructure for tele-emergency, for diagnostic purposes, for pharmacy, and now they have started some outreach services as well. So the project is being used for tele-education, for telecommunication. So you can put this network to additional use. And there have been many case studies, many examples in India. Next slide, please. The model, telemedicine model in India that is followed is hub and spoke model. Hub means we have a tertiary level healthcare facility or a specialty hospital, which is usually a medical college hospital where we train our MBBS, MD students. And spokes are the peripheral health facilities, which is close to the general population. These are usually district hospitals, community health centers, and you have primary health centers as well, and sub-centers. So I can take example of 2 states, Tripura. It has got 3 hubs, 24 peripheral centers, and it spans over 8 districts. Maharashtra, a very big state, it has got 6 hubs where we have a private hospital in the hub, we have a corporate hospital, and peripheral centers, we have 62. Peripheral centers involve 23 district hospitals and 39 community health centers. Next, please. Now, there have been a lot of challenges running telemedicine network in India. First is connectivity issue. Sometimes the audio is clear, sometimes the visual is clear. Both are not clear. So connectivity problems are there. That is the biggest challenge. Second, language problem. The patient speaks in his or her dialect, and the physician is not able to understand. So we have primary healthcare workers like ASHA workers. They help the female of the remote areas, because females, they don't come openly for the medical healthcare. Children, they don't come. Children are usually attached to their mother. So they need urgent medical help. And if mothers are educated, the whole family is helped. So you need some ASHA care workers. They help the mothers, the children to tell their problem to the physician. Third challenge is sometimes like for dermatology and radiology, the images can be uploaded on internet. But certain clinical situation, you have to physically examine the patient. In that case, we can have probes with the ASHA workers or with the healthcare providers in the primary care center, and we can have some segregated places where the patient can talk to the physician online, where there is no disturbance, because at home there might be some disturbance. So this can be done, and this is being done. Now, there has been very successful, although there have been challenges, there have been successful initiatives as well. India has surpassed doctor population ratio of 1:1,000. That is a very good situation. We had e-Sanjeevani going on during second wave of COVID. And we found there are a lot of consultations online and they increased. But telemedicine is not a gap-filling arrangement. It should be in the mainstream. It should be in the National Health Mission program of the country. It's not we have a pandemic and we switch on to telemedicine. Telemedicine should be developed with the normal care. There are many startups coming in India. And if I see the market analysis, although I am not reporting it over here, it's a multi-billion-dollar business. Yes. Any questions, please? I think this was my last slide.
Thank you, Dr. Dimple. Yeah, we are supposed to take questions after all the presentations is over.
Okay.
So please wait for the questions.
Okay. Thank you, sir.
Moving to the next, I think I got the information that the Mr. Zahir is ready for the presentations. Zahir, are you there?
Hello, yes, I'm ready.
All right, yeah. So please go ahead. Zahir is from the University of Malaya. So his presentation's title is Activities and Technical Updates in Malaysia.
Assalamualaikum. Hello, hi, good afternoon, everyone. Here I'm from Malaysia, and also good morning to people from the Bay. Okay, today I would like to present about activity update from my university. So this is brief information about me. I'm working with University of Malaya Medical Center for about 22 years, and I'm now the IT manager. Okay, and this is a little bit information about my institution. So it's University Malaya Medical Center is a first teaching hospital for Malaysia, and currently we have around 2,000 doctors, and we have around 6,000 supporting staff. The hospital size is about 1,600 beds, and we have around 5,000 inpatient. 5,000 outpatient and 300 inpatient admission daily. So about 2022 in Malaysia, we had started endemic phase, and the government of Malaysia had declared 1st of April 2022 is a Malaysia entering the pandemic phase, and where the situation where 99% of Malaysians get vaccinated, and there is no travel restriction anymore, and the business is open as usual with a not so strict SOP. Face mask is compulsory at that time, April, and after October 2020, there will be no compulsory on the face mask. So no more physical distancing required, and borders are fully open. So you can see, people can start dining in, and also, they can do the correction activities and classroom for school children and also running. Okay, but however, the good things from the pandemic situation, it still continue even though we had entered endemic phase. So things like telemedicine solution like Zoom still continue to be used, especially for the webinar. And because Zoom is very handy, we can use for cloud recording, and also we can also stream to the Facebook or YouTube at the same time. And other than that, we also use Google Meet. Google Meet is very simple application, also quite free. We can actually we use for e-learning and a virtual class, and sometimes also we use for meeting. We also have used Microsoft Teams for a team member meeting or also discussion. And we also have our in-house mobile apps that we developed for teleconsultation. Actually, it started from during the pandemic when we have a total lockdown in Malaysia. And then we use also the application for home monitoring purposes. So for teleconsultation services, we are using telemedicine, and we are using that for follow-up patient. So basically, if you can see, this is quite a simple setup where we have a small video camera here with a microphone, and we have a USB speaker. Actually, these are two additional equipment that are attached to existing computer in the ward. In the clinic. So basically, for the doctor to use to communicate with patient. And you can see on the photo on the right, we had additional screen for because our hospital is using EMR, so doctor have to write down all the case note, everything on the other computer, and the other screen basically to communicate with the patient. So I think you can see it clearly from the photo that this is a remote patient. Okay, so currently, I think since 2021 until 2022, we had rolled out this teleconsultation services for almost 27 subspecialties. Okay, and it involved around 125 doctors and 1,278 patients already been through using this teleconsultation services. However, for doctor to do the telemedicine or teleconsultation, they have to come to the hospital because for the EMR policy, we have a quite strict policy, so they don't allow doctors to access a medical record from remote, so they have to come to the hospital. Okay, because of this development time, we need to launch the services as soon as possible. So basically, we just develop a portal, and the portal can integrate with the Zoom. Basically, the Zoom, we had predefined the appointment slot, and the link will be automatically programmed into the portal. So whenever a patient log into the portal according to their time for the appointment, so after they have done the payment, so they can see the link available and they can click the link. So the link will open and the Zoom application will open to the patient, and then go into the waiting area, and doctor will drag them into the meeting room whenever they are available, or whenever they are available to do the consultation. Okay, and doctor then consult the patient, then he will write the prescription. Okay, and after the prescription is ready, so patient can go back to the portal, then they can do the payment for the drug, and the drug will send to the home through delivery services. So other than that, we also use telemedicine services for the medical training. So this is one of the example that we have e-lecture for master's student and also PhD student for the lecture. And also we have conducted many webinar, even though we have entered the pandemic phases. You can see this our doctors and also our engineer, Mr. Hafiz, conducting the technical webinar. Okay, basically, this is my meeting room, in my department meeting room. So we convert to a studio temporary because at the time, we don't have a proper room yet for the telemedicine. Okay, this is also another webinar. This is infection control webinar, also using the same room. I think you can see the setup. Last time we had set up in the other corner for the control room, but now we move to the other corners. Okay, there's equipment for audio. Okay, this also, I think about similar setup also for the staff assembly. So you can see that our Zoom can support up to 1,500 packs. And at the same time, also we stream to YouTube, to our YouTube channel. This is also another meeting for the staff. And it's this one for 5,000 packs. So actually this one through streaming for 5,000. Okay. And this is our new engineer sitting next to Mr. Hafiz. His background is network engineer, but we train him to become the telemedicine engineer. Okay, this is another live workshop that we have for endoscopy 2022. The event date was from 3rd to 4th of June. So it's almost cater 800 participants. Okay, where we have local and also remote participants. So it involves live cases, and also there is also a surgery. There are about 30 surgeries coming from 40 where we broadcast simultaneously, and then the moderator will just switch between the OT for the case presentation. Okay, this is another photo of the setup from the OT room. Okay, you can see this is Dr. Ho holding the scope. Okay, this is also another international webinar or live workshop. So we have this one for Asia Pacific Hand Hygiene Excellence Award conference. So also we use the same room. Okay, this is also another event. Okay, other than that, we also use a telemedicine facility for research audit. So where we are using Zoom, basically, we will connect to the sponsor using the Zoom, and then we share the computer. And by having Zoom, we can have a remote control function. So we pass the remote control function to the auditor, and the auditor will review our AMR. So this is also used when the auditor cannot travel last time, but even though in endemic phase, we still continue using that. Okay, other than that, also we are using for exam and Viva. Okay, this is from Google Meet. Okay, so we have a student to present, PhD student in present, and the group of panelists will review from the other end. Okay, and also for some courses, we still have our virtual classroom. So we have students connect using the Google Classroom. Okay, and for ongoing and future plan, this is the application that I'm talking about from the beginning. Is what we call as our telemedicine app, or we call the name is We Help. Okay, under the We Help application, I mean we can have home monitoring for the patient. It attached to the patient blood glucose machine. Also, it also can connect to BP meter, and is synchronized to the phone, patient phone, and doctor can review real time the information about patient vital sign. And also we have a teleconsultation as well, but linked to our Zoom. Okay. Right, and other than that, also we are now developing another application we call telehealth apps. Okay, from this app we call as a patient journey. So patient can do registration, appointment, self check-in, the payment, request for medicine, request for medical record, and also integrate to IoT devices that I talking before. Patient can do self-monitoring. Other than that, doctor also can do remote monitoring. There will be a function for telemedicine for teleconsultation, and also patient can see the health record. So basically, this application will simplify from the portal that we are using before. Okay, and we also are going to set up a telemedicine center. Basically, this project was started from last year, but due to the budget constraint, we will do this year, and hopefully we can complete by Q3 2020. So basically, this room, the one that I showed before, actually is a meeting room in my department, but this is a new dedicated room where we try to renovate to become something like telemedicine studio. So you can see this setup, there will be like something like control room, screen, and I think 5 sitting for the speakers. Right? Okay, other than that, we also have built a health command center in my hospital. So basically, this health command center basically to monitor hospital bed management and monitor clinic waiting time. And also you can see, you can monitor visitor monitoring. So from the health command center, so basically we'll expand into a telemedicine hub. We call as a virtual hospital within hospital by next year. So basically, from the command center, we will extend. We can put nurses and also doctor here, basically for them to do proactive home or remote healthcare monitoring. Okay, so actually the patient will use the app, and the data will fit into the server, and doctor basically can monitor the patient real time. And they can have teleconsultation on demand whenever required, whenever they see a abnormal vital sign from the patient. And also this will be used for hospital, pre-hospital consultation. Okay, for the activity summary, if you can see, these are list of the technology or system that we use. And probably I would like to highlight after COVID came in, 2020 up to 2022. So you can see we have a lot of telemedicine sessions coming because of this physical, travel restriction. So in terms of technology also, you can see that we are moving for teleconsultation from Zoom into Google Meet because Google Meet is quite simple and it's also free. So that's why you can see we are replacing our Zoom for the teleconference conversation using Google Meet. Okay, next will be my last slide. Okay, so in conclusion, there are many technologies or solutions available for telemedicine. Okay, but most importantly, you have to choose the one that will meet your requirement. You have to see the potential of a solution in terms of features, costs, pros, and also cons. And whenever you do this solution or you implement the solution, always plan, do check and add on the outcome, whether it meets your requirement and especially your patient or your user. And the combination of telemedicine and telehealth, I think is the way to go because it will produce the best result. By having telemedicine without telehealth, I think it may not really give the best result. So finally, I would like to thank COVID-19 in the other way because I think by having COVID-19, the people mindset or perception totally different, especially when we go to telemedicine. Because sometime last time, I mean, there's still some reluctance in terms of using technology. But after COVID came in, when no people can travel, I think they will use the technology fully. Thank you. Bye-bye.
Thank you, Mr. Zair, for your presentations, and it's very impressive presentations. And there are a lot of activities we can implement in other part of the world as well. So please stay online. We will have the Q&A after this presentation. So we're almost at the end of the presentations. So the last but not the least, we have Mrs. Kuriko Kuro. She represents here Telemedicine Development Center of Asia. She is also the assistant professor at Kyushu universities, and she is one of the technical leaders who has been assisting for these engineering workshops in ATS events. So our presentation's title is MedHawk Development of Management System for International Telemedicine Conferences. Over to you, Kuriko-san.
Thank you, Chairman. And ladies and gentlemen, it's great honor for me to make presentation here in ATS in Nepal. So as you already know, there's two types of telemedicine, doctor to patient and doctor to doctor. And my presentation is focused on doctor to doctor, especially international activity. And we are secretariat of the APAM Medical Working Group since 2005. And led by Dr. Tomohiko Moriyama. And we have the variety of the activity twice a year. And in each conference, organizers from Asian countries hosted a variety of programs in various medical fields like surgery, endoscopy, dentistry, ophthalmology, traditional medicine, etc. However, these kind of activity supporting have the administrative barrier. As you know, the recent video conferencing system like Zoom or Meet have made it possible for anyone to organize a conference by sending the connection link with the potential participants. That means we need to manage the potential participants. And also, after COVID-19, fee-based program management system were in service, such as Hoover, which is used in this conference as well, but it's built on per event basis. So as you can imagine, if we have the routine international telemedicine conference with our many network on the voluntary basis by unlimited staff have the challenges, such as inviting participants from various hospitals in the world, managing institution and members precisely, managing multiple programs, and expanding the program to larger audiences. And we have developed MedHawk, that is International Telemedicine Program Management System, and implement it in the medical working group since 2014, 5 years before COVID-19. And we explored the conference organizers' task and evaluates MedHawk through the survey of APAM Medical Working Group's program organizers. So this is the workflow model. So we, APAM Medical Working Secretariat, TEMDEC, supported the program organizers, and we developed the MedHawk, the management system, and we store the institution information and member information, and give the arrow to use the information to the program organizers. And the program organizers have their own system pages of including the conference program and mailing list. Mailing list is a participant list of the conference program. And the conference program have the information like the day and the time, topic, presentation title. It's a normal symposium program and also. And the participant is just the information of the addresses, email address, name, institution. And the program organizer inviting many hospitals in the world, and each hospital have the participants. So after making the conference program and mailing list, program organizer or we announce the connection link using the mailing list. And after that, in the actual program, this program information is open in the homepage, and we also invite many our whole member to see just the activity through not interaction, but just receiving as an audience. And the audience can, through the registration form or just getting the link, they can see what is happening in the conference. So this is a workflow design. And this is our database structure. Roughly, database data is stored like the institution and members and the event details. And each member is affiliated with the institution, and each event referred the members and the institution which only the participating in that event. And when the member information is updated or institution is updated, then all the event who join is also all updated in the multiple event. And each event have the member list and the conference program. So this is the user interface of our system, and each event have the program and the mailing list, and it's combined. And people can see get the streaming information from this button, access information. And the connecting institution is listed and numbered. And in the schedule, the candidate of connecting institution can understand the local time. It's also in the database. And after the organizers push the button to open the program, then in the homepage, there's automatically appear the coming events. Then anyone can can access this program and get the access information of the streaming. So in our activity, we investigated all event program using MedHawk from June 3, 2015 to 2012 June. And we analyzed the effectiveness of the system using a questionnaire by 4-point Likert scale and a user experience questionnaire. So this is the result. This is one characteristic of the respondents. The person who editing the management system were mainly physicians following engineers. And the scale of program in medium, the 7 countries, 10 institutions, and 44 members were in each event. But in largest case, 25 countries, 49 institutions, and 194 members managed by physicians and engineers. And here is the most burdensome task. And of course, the confirmation of member information is most burdensome. And this is evaluation of the system. So over 90% of the answerers rated positively for MedHoc for the confirmation of institutional information, members, technical information, and maintaining the latest status of the program, and announcing publicizing the event. But the less people said positively for formatting and correcting misspelling. And this is a new thing enabled with use of MedHoc, and the confirmation of institutional information, maintaining the latest status program. The publishing the event is more people said. Also, no one said nothing new by using this system. And the user experience was generally positive. And we have some comments, especially I like to introduce the system updating requirement, and some the program doctor want to the organizer want to edit only the program, but the member list would like to manage by Telemedicine, because so many members and institutions, that is very troublesome. And also they needed to ask Telemedicine to register the information for the institution and the member, new member information. So yeah, they want by themselves. And also we get some the comments of the updating the system, and some the predictive system can be available is good rather than the drop down list. And also we get some good positive opinion regarding this system. So as a conclusion, the international telemedicine conferences were managed by BG doctors and engineers. The largest case of conference was 169, 94 participants from 49 institutions in 25 countries, and it's usually increasing because they are routinely organized and inviting many institutions and participants. And managing participants and institution were taking time. And more than 90% of participants respondents evaluated MedHoc positively, and the user experience was also positive. Our system allowed organizers to publish their programs without delay. However, the system operational improvements are needed. So that's my presentation from the article, which is we published in this year. So if you are interested in, please see the detail. And we are so grateful for the cooperation of all program organizers and engineers, participants in the EPAM Medical Working Group. So thank you very much.
Thank you, Kuriko-san, for your presentations. Okay, with this, I think we have concluded all the 6 presentations, and now we are moving towards the Q&A sessions. There were 6 presentations, So the floor is open for the Q&A. Is there any questions for presenters?
So can I ask a question? So thank you for your the remote presenters. I especially impressed the Mr. Zahir presentation regarding your the teleconsultation activity. So you are the you ask patient, you charge the patient to use your system when you give the teleconsultation, or it's free?
Okay, basically, the telemedicine or teleconsultation session will replace the physical patient visit. So basically, the charge that we charge actually the same with the same clinic registration fee that apply to the physical consultation. So, but whenever patient join the teleconsultation online, so they just pay the registration services fee. So actually, it's about $2 around that for the patient for the registration.
So the $2 for the additional payment for the giving support and
Not the additional. There is not additional. There is what I call the clinic registration fee.
clinic registration fee is needed
Registration fee. Yes.
for you ask patient, you provide these services, patient same cost of the
Yes,
in-person
correct.
visit,
Yes, the same cost.
and
Yeah.
just the $2 is additional.
Not the $2 is not additional. $2 is the standard registration fee for our hospital for
I
clinic
see.
consultation.
So that means your the technical equipment is supported by you. And
Yeah,
you cannot get
our-
additional charge.
Yeah, we don't get additional charge for that because the reason is we want to encourage the doctors and also the patient to use the telemedicine services because we had started this project I think middle of 2021. So about a year after COVID came in, when we have a problem with some patient which not so actually is long-term medication patient and they cannot travel at the time because of Malaysia implement quite strict movement control order at the time. So that's why some of the patient doctor cannot see them for almost more than 6 months. So by having this teleconsultation, we can offer to those patients, usually diabetic patient and hypertension patient, so we can have a remote consultation using this Zoom facilities at the time. So, but in terms of our hospital administration, especially finance department, they still insist us to collect fee from the patient. So actually the fee is the same the fee that apply to physical consultation. It's just that they don't have to come to the hospital and they don't have to see the doctor physically. Okay, so that's why we still apply the charges. There is no additional charges because we want to encourage patients to join this program.
Oh, great. Yeah, telemedicine can possible to give the more opportunity to get the
Yes.
patient. Yeah.
Right, yeah.
Thank you for your nice comment.
You're welcome. Always. Okay.
I wanted to ask Mr. Zahir a question. He was talking about that We Health apps. So you
Yes.
need a smart, like a band, like smart. So is it provided with the apps, or how much does it cost to use
Okay,
that apps?
we have two models. Actually, the apps is using what I call is developed based on iOS and also can be used for Android.
I saw it's in the iOS also. I tried to register, but I wasn't able to register from here.
Oh my God. Okay, I hope you I think you can register using generic email. Okay. But to link to the hospital, you need your what I call nation identification ID to be registered in the system first, in order for you to use the system to link for our hospital. But to use as a what I call health monitoring, I think you can use it for free and you can register using your email. Okay, basically this application is free for the patient. You can download and it can sync with your wearable devices. Okay, we also offer our own devices. This one we work with our university. There is a spin-off company under the university, Faculty Science of Technology. So we had developed this wearable. The patient also can buy. We have an option for the patient to buy. I think the price is about $50, if I'm not mistaken, for the wearable. I mean, it can read SpO2, it can read BP, but not glucose. Glucose is glucose on the other machine, glucometer. And also our bundle also we offer the waiting machine also can sync to your phone also. So basically, all this equipment will sync with your phone, and then from the apps, it can capture data and also can send to our server. And doctor can review all this result, all this what we call trend data whenever they have a teleconsultation. Yeah. I hope I answer your question.
Thank you.
Yeah.
Thank you, Jahir. So is there any other questions for the presenters? Okay. If not, then I have one questions to Yukiko-san. Yeah, it's very glad to know about the 360 live demonstrations, as TEMDEC and Kyushu universities have been very cooperatives to disseminate the knowledge that they gain from the new innovations as well. And some of the engineers are already participated for these sessions. Just wondering, do you have any other plans to disseminate your knowledge to other countries, so that this can be very useful for others? And maybe we can think about the trainers type of training, so that engineers from the different countries can disseminate their knowledge to their local engineers by themselves. Yeah, that's all.
Yes, thank you very much. Yes, I strongly want to continue this program, but not yet planned next one. Yes, maybe we can plan soon. Kuriko-san, can you?
Yes,
Could you add? Yes,
yeah, thank you, Isada-san. I'd like to add one comment. Now we are having a next year's project, which is development of a training program, e-learning engineers training program. And we are now checking what is good for the program. And we think the 360-degree, the live demonstration is very nice. Experience. So thank you, Rajan, for your nice comments. And also we would like to keep the discussion with the doctors and engineers about this.
Thank you, Kuriko-san. And thank you, Yukiko-san.
Thank you very much.
Thank you. And Satya-san, you want to have a question?
Yeah. I have two questions. I think one is on the 360 degrees camera. I would like to know how far this 360-degree camera is useful for the doctors in endoscopy suites. I feel it is more appropriate for the surgical people where they operate open surgeries or anything. That is my first question. And the second one is to Kuriko-san. Just can we organize some like endoscopy live programs in association with TEMDEC, where we can demonstrate like complex procedures, like new procedures like perioral endoscopic myotomy, POEM and ESG, for obesity treatment, and those critical procedures, can we have a combined programs for educating on for the doctors?
Okay.
Hisada-san. Yeah, please.
Yes. Yeah. Thank you, Satya-san. Yes. Yeah. I think we can apply this 360 degrees camera to not only endoscopy but also surgical or many other hospital what I say hospital operations.
I mean,
Yes.
the usage of the 360-degree camera in endoscopy suites, how technically this is useful? That's what I wanted to know.
Oh, how excuse me?
No,
Okay.
will it make sense with the existing camera, what we are having? Like endoscopy procedures are all complex procedures. All accessories will be demonstrated by the doctors, the scope. The more important is the endoscopy view, what we see inside the stomach. In the surgical area, it is entirely different. We have to see so many activities in the OT. That's what I mean to say.
But you want to know the if the 360-degree camera used inside the human body?
No. That is not possible. That I can understand.
Yeah, please.
Okay, Satya, thank you for your good question. This is just a weak point of the 360 camera and endoscopic procedure. Actually, endoscopy itself, I'm myself an endoscopist. I just would like to watch the endoscopic images, and of course, I'd like to watch the technique of endoscopist there. So that's why the 660 camera can be useful, but not necessary, I think. If you prepare the two camera, one is for the endoscopy and others for endoscopist, it's enough. But for the surgical procedure or other medical procedure in emergency department or something like that, we can see that kind of the coordination, cooperation between the doctors and the medical staff. In that situation, this camera should be quite useful. That's why I would like to expand this kind of 600 camera live demo to other fields. Thank you for a good question.
Yes, sir. Thank you very much, sir.
So connecting this, you have connecting this topic. I'd like to also ask if someone know if any cases and any medical procedures it's good for the 360-degree camera. We are so glad because we are now seeking the adoption of this new technology. And also, I'd like to answer another question from Satya-san. You asked us how about organizing the endoscopy lab demonstration more integrated with some different contents and different techniques of endoscopy, including the POEM and the ESD and still we don't have actual plan, but we are very happy if we have. And because we have many international institutions, international friends, and who can make streaming out to us. So if we have chance, we could happy to organize.
Sure. Thank you so much. We can coordinate that case.
Thank you. So any other question, comment from anyone? So if you note, it's already time is past. So thank you very much for a nice presentation from the international participant. And also thank you very much for a nice comment, discussion, and the venue as well. So I'm very happy to close this session too. Thank you very much.
Thank you. Thank you for active participation even in the second day. And it's already lunch hour. We must have been very hungry. But before that, we have very eminent persons here who have worked hard in telemedicine. Yesterday, we felicitated first generation telemedicine seniors. Now today, there are second generation young telemedicine experts whom we are going to felicitate. So I would like to invite Dr. Moriyama to present the, we call it Samman Patra to our Lochan Lal Amatya sir, who is chairing Nepal Research Education Network. He has been involved in telemedicine for long, and his contribution, we all know, it's been decades that he has been working hard to develop this telemedicine. Thank you, sir. Thank you. And I would like to request Lochan sir here to, I'm again another young person to felicitate Dr. Bhushan Raj Shrestha. He is also the immediate past president of Nepal Research Education Network, and we all know his contribution to telemedicine again for decades. Thank you, sir. Yeah, Lochan sir will be handing over the. यो म पढेर सुनाउन चाहन्छु आज पनि सरहरूलाई। नेपाल टेलिमेडिसिन सोसाइटी सम्मान पत्र। यहाँले नेपालमा टेलिमेडिसिनको विकासको लागि गर्नुभएको अथक मेहनत र प्रयासको उच्च सम्मान गर्दै नेपाल टेलिमेडिसिन सोसाइटी साथै नेपाल रिसर्च एन्ड एजुकेसन नेटवर्क तपाईँ लोचनलाल अमात्य सर, डाक्टर भूषण राज श्रेष्ठ सर ज्यूलाई यो सम्मान पत्र प्रदान गरिएको छ। थ्याङ्क यू। Thank you. Now we can start lunch, and we'll start WHO and government combined session. Thank you.
Hello, test, test. Hello, 1, 2, 3. Hello, test, test. Hello, 1, 2, 3. Hello, test, test, test. Hello, 1, 2, 3.
Good afternoon, everyone. Welcome back after the lunch break, and we'll be starting the last session for this workshop. So in this workshop, we will be hearing from our eminent speaker from WHO and the Ministry of Health and Population. For this session, I would like to request Professor Dr. Tomohiko Moriyama to chair the session, the director of the TEMDEC. Along with him, I'll also like to request our special guest, Dr. Madan Kumar Upadhyay, is the Chief of the Quality Standard and the Regulation Division of MOHP, and also Head of the Digital Health, Ministry of Health and Population. Thank you, sir.
Okay, this is our last session of 2 days, this symposium. But maybe this is a most important part for the Nepalese doctors and engineers and the commercial company guys who are quite interested in install the telemedicine in clinical setting in Nepal. So we'd like to invite the first speaker, Dr. Udeya. So I will pass the microphone.
Hello. Thank you. Thank you, everyone. First, I'd like to welcome you all. Welcome Dr. Madan Kumar Upadhyay. He is Chief Quality Standard and Regulation Division of Ministry of Health and Population. He is also the lead of digital health in Ministry of Health and Population. Similarly, Pawan Kumar Gimire, he is National Professional Officer in HIS in WHO. And Rajendra Prasad Paudel, he is IMU ISIMS Digital Health Advisor, DOHS MOSP. So thank you all for the presence. This will be our last session, but the very important session, because we are actually handing over our declaration, the whole workshop, what was the conclusion, what was the discussion, and we will be handing over this to Ministry of Health, and hope in the future they will look upon it and go for regulation and guidance. I want to read the declaration. 16th Asia Telemedicine Symposium and 3rd National Telemedicine Workshop 2023. On March 17 and 18th, 2023, the 3rd National Telemedicine Workshop and 16th Asia Telemedicine Symposium was conducted in Kathmandu with over 90 participants from Nepal and various parts of the world. The workshop was organized by Telemedicine Society of Nepal and Nepal Research and Education Network in collaboration with Telemedicine Development Center of Asia, Kyushu University, with support from Nepal Telecom Authority, World Health Organization, Nick Simons Institute, and Nepal Telecom. In this highly intensive workshop, 3 main topics were discussed: experience sharing in telemedicine, telemedicine in different parts, institutes of Nepal and different countries, role of nurses in telemedicine, future of telemedicine, standards and guidelines. Since our last declaration in 2019, which was our 2nd National Telemedicine Workshop, there have been significant improvements. Today, we have telemedicine guideline for registered medical practitioners by Nepal Medical Council in 2020, telemedicine and online health services protocol by Nepal government, Ministry of Health and Population in 2077 BS, increase in the number of research studies, increase in the trend of implementing telemedicine services in various health institutions. We, the participants, appreciate that information and communication technology, an important component in telemedicine today, is becoming widely accessible and affordable. Besides primary healthcare services, more and more specialties are being involved in the use of telemedicine, such as mental health, ICU, geriatrics, maternity, pediatric, physiotherapy, rehabilitation, urban health, cardiology, orthopedics and trauma, and others. Growing number of engineers and healthcare workers are working collaboratively for successful implementation of telemedicine. Government of Nepal has been involved in developing telemedicine services. Advancement in telemedicine will enhance healthcare access and decrease. We feel the need for standardize of telemedicine and its SOPs for all practitioners, update the telemedicine guideline and make it context-based, suitable with the geographical constraints, population awareness, and level of technological advancement in Nepal. Form dedicated department within the Ministry of Health and Population in coordination with Ministry of Science and Technology and Ministry of Information and Communication to govern and regulate the telemedicine system and activities in the country. Form telemedicine expert group, including different personnel and institutions actively involved in the development of telemedicine in Nepal. Adequate budget allocations by Ministry of Health and Population, Ministry of Science and Technology, and Ministry of Information and Communication for continuation, development, advancement, and regularization of telemedicine. Use of telemedicine for knowledge sharing and education among national and international communities. Formalize regular and effective training program to all personnel involved in telemedicine service. Proper and adequate reimbursement of the human resources working in telemedicine. Intense need for directives and protocols from Ministry of Health and Population, followed by orientation of stakeholders in telemedicine. While governing the health care sector, it is equally important to regulate the health software development systems, including maintenance of patient privacy and data security. Inclusion of nurses and paramedics is important for the advancement of telemedicine. Institutionalization of telemedicine activities in Nepal. Focus on less privileged population as one of the principal beneficiaries in telemedicine services, whether they are from remote or urban area. Empower the healthcare workers at the receiving end while promoting and implementing telemedicine service practices in the rural and remote areas. We, the participants, are collectively committed to working in our respective roles and support in the development of telemedicine activities in Nepal in order to improve cooperation, communication, and coordination among telemedicine enthusiasts, practitioners, and engineers. Organizations like Telemedicine Society of Nepal, Nepal Research and Education Network must continue to play a significant role. We, the participants, are thankful to Telemedicine Society of Nepal, Nepal Research Education Network, and Telemedicine Development Center of Asia for creating this platform, and will continue to support in the implementation and expansion of telemedicine activities in Nepal. We, the participants, also agree that this workshop has motivated us. We have used this opportunity to talk about issues that are crucial for increasing access to healthcare and safe clinical practices through telemedicine. Thank you all. And especially thank you, Dr. Madan, for giving this important, valuable time to us. Thank you.
Thank you, Dr. Uday. I think these recommendations will be taken on consideration by Ministry and Government of Nepal as well. Now this time for sharing a few things from WHO, Ministry, and as well as the advisor. So I want to invite Mr. Rajendra Prasad Paudel to share the roadmap for telemedicine in developing countries. Thank you.
Thank you, respected Dr. Madan Rakshap and other professionals, key speakers for this 16th Asia Telemedicine Symposium and 3rd National Telemedicine Workshop. So basically my presentation is more focused on that how countries like Nepal should have to develop their roadmap and what are the key things that need to be considered. So my presentation is not like as a showing the what sort of roadmap. It's not showing the roadmap, but what are the considerations that we have to follow. And especially yesterday, I have I stay for a whole day and I listen a lot of things, and I realize this session is more on the summarizing of yesterday presentation. So I think this is more on the background that has been yesterday also many presentation I have already addressed. So in case of Nepal, we have got 55% of health facilities have computers and internet facilities. And also through the NTA report, the population level 15.4% household have computer and 51% household have internet access at homes. So e-health activities is formally started from 2 decades ago. And the first e-health telemedicine was connected in Nagi village that was established in 2001. Then after that has been followed by other many organizations like as a HealthNet and many other private and public organizations. So in 2010 and from 2010, government also started the rural telemedicine program. And yesterday we have already heard about the story about it. And this is Hello Health. And in 2017, the ministry had developed the e-health strategy roadmap. In 2019, that was started in 2017 and ended in 2019. And National Health Policy 2019 spoke about the telemedicine. So most of the issues that we have talked about yesterday that has been addressed in Public Health Service Regulation Act and also National Health Policy 2019. So, and also there is a lot of initiative that has been started by many organizations during the COVID pandemic. For example, like as Amakomaya is one of the maternal health tracking system, which have a largest database to connect mothers, pregnant mothers. So focus to my presentation, that telemedicine roadmap is a strategic and stepwise plan to implement the telemedicine. So this should help to understand the key challenges, pinpoints, and opportunities for implementing telemedicine in Nepal. So in case of the Nepal, there are a lot of documents that we have already developed that supports for the development of roadmap for telemedicine, like as a national health policy and public health service regulations and telemedicine online health service delivery guidelines. And also that has been similar guidelines that has been developed by Medical Council and Digital Nepal Framework. It has clearly stated about the telemedicine, its features, its even its benefits and its beneficiaries, and e-health strategy roadmap. It has got a separate chapter for that. And just recently, just last year, integrated IHMIS roadmap that has also clearly stated. So these 7 documents are the foundation for the legalization and regulation for telemedicine. And as per the digital health building blocks, there are the 7 building blocks. These are the major things that we should not have to miss when we are designing the telemedicine roadmap. And the telemedicine is one of the component, is a major component of digital health. So, like as this leadership and government is very, very important. Until and unless there is not the strong leadership and the governance, we cannot, even there is a good roadmap, we cannot move ahead. So that is very much important. And similarly, other like as a strategy and investment. The second thing is the financing. The financing team is to the telemedicine is very, critical, because it is based on the technology, and technology has always the limitations, and technology is directly connected with the return of investment. So that is very important. And what sort of services and applications that can run through the telemedicine, and what sort of standard that we have to adopt, and as per the infrastructure, telecommunication network, broadband network, and the regulations, these things. And also similarly, the workforce, the trained workforce. So these building blocks is very important, and this has been developed by a WHO digital guideline. So origin of roadmap for telemedicine start from the conception, especially before we start preparing the roadmap, that what we need to realize whether we really need the telemedicine and where we need the telemedicine and what sort of value that we want to create from the telemedicine for the services, and who will be the target beneficiaries, and what sort of like as a capacity to exchange the data from one system to another system. Even telemedicine can exchange the data from paper-based to digital-based, and digital-based, how it can be even manual to digital. That is another challenge. And where does this services fall? Because the technology have a very high range of hierarchy, from basic to advanced system, where our telemedicine system will fall. That's very important to identify. And how we can make this telemedicine service trusted, well trusted by citizens. So these are the major things that we consideration that we should not have to do compromise when deciding these things. So the first step is financing to telemedicine project, that is especially measuring the return of investment. When we are designing telemedicine, that is very important, that how we will return our investment in the technology. Because always when we are installing for the technology, it is not like as a building which have got 50 years of lifetime or 30 years of lifetime. Mostly technology have got maximum 3 years of lifetime, because there are a lot of new advancement are coming, new patches are coming, new technology is changing. So that's why within a 3 years of timeline, how we can get the return. So that is very important. So that's why the more investment goes to installation of telemedicine equipment in the hospitals, and providing the client-side interface to access the telemedicine service which is placed in the hospital. If we have got advanced system in hospital, then clients should have to be same interface to access them. That is the most important things. So when we are installing things, then we have to purchase the software. Software might be open source or licensed, and installation for like as a telemedicine service should be available 24/7. It is similar like as an emergency in hospital, and installation of dedicated network and data storage and management, like as a when we are going to storing the data, CT scan and MRI images, they have a huge storage. So how it, and hiring the dedicated HR is very important for the when we install a telemedicine. So outcomes should be one-time cost for installation and server system, but monthly recurring cost for apply for the power, internet or network cost, and the storage space and applications license and the HR. In similar way, for the client side, clients should able to access that technology which is installed in the hospital. That should be like as a whether client can purchase or they can rent it. Sometimes the client can rent it for short time of period. For example, the pregnant mothers, if we have got the pregnant monitoring system, they can rent for 6 months. Then soon after the delivery, they can return that equipment. So whether we have to make it purchasing or like as a renting, and clients should have access to internet and network connection. That is the cost of, still the cost of data connection in Nepal is still high. So how we can reduce that one? So that's why this cost, and telemedicine, when we are talking about the uses of IoTs, Internet of Things, that is the small things which is connected with the internet, and then skilled human resource, electricity, power. Even the users should be they should have a skill to use the access of technology, and continuum care through the use of telemedicine. That is the monthly recurring cost. And also that establish facility for patients, like as a registration online portal. If we want to go more higher level, then we can manage the appointments. And in that case, there will be a lot of unseen overhead costs during the adoption of technology, because when people are going to adoption, sometimes there is a frustrating time. Sometimes there is a lot of people, because they need to fill the forms, they need to again fill the form in the computers. So these things, and training and incentives for the health professional is very important, because we are going to giving them extra work for accessing the technology. So how we can do those things? That's why another one is the activities to change the patient's behavior is very important, whether they trust on the technology or not. That's more specifically like as how we will reach out to the publics, like as a digital ad, social site boost, or digital campaign. Then we can reach to the even broadcasting about the telemedicine services, about the radio or television. So that's why for certain duration, for creating the awareness to the citizens, it takes the time. So that's why activities of, and then once we did this everything, then there will be some data. Those data need to be used for the decision-making process, that is more useful for the policymakers, that is more useful for the clinician, especially clinician for the decision-making. So that's why that sort of analysis systems, dashboards, and then those things, that is very important. And most important is the technical support. We should have a call center, toll-free, for providing the technical supports. Whenever they have a hospital face problem in the technical side, or like as a client face the problem in the technical side, they should able to contact to the technical support. And similar way, return of investment is always expected from the receiver side. The previous two slides, I spoke about the return of investment from the investor side and from the client side, or like as a side, how they need to, like as how they are going to subscribing the telemedicine packages. There might be the different packages, services, and then how this 24/7 virtually health professional, they can be touched to each other, reduce the mobility, it will help the cost for the mobility cost, and they can save the time. But in the same time, the cost for the package will be applied, and they also need to have a good internet bandwidth to have a video conferencing. And for also for the purpose of laboratory, they have to visit it. They have to the laboratory. In that case, the radiology images, that is the huge, like as a high resolution images with the huge weight that need to be sent to the telemedicine, like as where the clinician is, like as is working. So that's why these things are very much important. So some example of high value measuring ROI in telemedicine. So which sort of applications have a high return of investment will have the most return of investment has been like as a measuring till that has received 58 number is mother and child care, then rural health care, trauma and emergency, especially the road accidents and chronic disease, and then geriatric care, mental health care, and training for the health workers. So these are the major area where the return of investment is assured. Even we have worked with the limited technology, it is possible. The second, once we have got technology in place, the second is most important is the behavior of the patients. So patient empowerment is very much important, that how they can engage with our system. how they can be self-managed with their system, how they can access to the technology, how to ask technology for the support, how they can ask for the, if they have got problem, where they have to ask. And that's why we need enough tutorial materials in the language they speak. We have got almost 120 different type of dialects here in Nepal. So how these peoples will able to come to access these telemedicine systems? And right of patients and privacy. What is the rights of the, like I said, we have got Customer Rights Act. So through that act, what is the rights of the patients in telemedicine and their privacy issues? And the most important is how to create a trusting environment with the technology. This is most important for the, in the patient side that we have to consider. The third important thing is that once we have got data, travel all the system, those data should be exchanged to each other. So that's why there are some sort of standard. It is not mandatory that you have to follow one single standard, because technologies always have a technology capacity to talk with the other system, because when the innovators are developing their technology, they're always taking care in their mind that my technology should communicate with other technology. That's why HL7, FIRE, and other many standards are there. And DICOM, that's a digital image and communication medicine. That is one of the important things. And similar, like as a clinical document architecture, this is very important. That is the standard architecture we have to follow during the design of telemedicine and design of EMR. And also other more national health information network systems that we have to follow. Then once we establish these things, then we have to categorize where we will be fall, where this will be fall, whether we are providing services for the primary telemedicine service. And each service have got the 7 different parts. Like as a primary telemedicine service is more with the lower investment, more for the rural healthcare, more for the like as a simpler technology. And secondary telemedicine, that is more on the like as a storage of the image. Then after we can explain that one, especially for the offline and online, both facility will be available. And territory telemedicine service, this is most advanced system, which is connected with the multiple devices, multiple doctors, and multiple, like even directly connected with the laboratory. So all this should have, whether they are real-time medicine, whether they are telemedicine or store and forward telemedicine or remote patient monitoring or mobile health, wherever we can use, there is no any limitations. New technology will come, we can categorize them and we can classify them in these 3. So as per these 3, then after the service technology standardization and benchmarking, this is most important to get this is the time to return back your investment. If you come in this step 5, your investment should be assured here. Then when your technology will be benchmarked, if you have got good SOP, if you have got good practice guideline for your practitioner, for your patient, for your technology designer, and if your international standard certification, if your application have a standard ISO and security certification, and there is a lot of like as a storage and transmission formats, which is compatible with the data exchange with different system and standardization, and then ICD code. Right now we are running ICD code, and ministry have already rolled out with all the hospitals here. ICD 11 has been already rolled out. And if you are able to integrate these systems, then you will have your applications will have a high value. Then after that, broadband internet, that is especially proportional. It is very important that your internet bandwidth should be proportional for the bandwidth as per the application requirement. If you are doing the 2-way video conferencing, you might need huge bandwidth. If you are going to streaming, you need more huge bandwidth. But if you are simply doing the web camera, then you doesn't need a huge bandwidth. So that's why it is very important. Then what sort of EMR or EHR systems you are providing, and what sort of clinical decision support system. This is more on the data analysis part and the dashboard part. If you have got these systems, then you have got the technology architecture, you have got the application architecture, data architecture, and ultimately the business architecture, which is their benchmarking of your business. And that is the place where you can return your investment. So that's why software development is never ending process. Software never ending, because every day there is always bugs. Every day you will find a new systems. Every day you will find a lot of, like as a requirement, new users will have a new requirements. That's why we always release newer upgrade version. That's why when we were starting Windows 95, now we are using Windows 2020, I think 2018 or 16, something like we are getting now. So that's why even in the operating system, that much of things are growing up. So that's why even in the telemedicine, it's never ending process. You have to release new version. But the product owner lock the development to save the further investment. Is a product owner, who is the product owner? The person who implement or deploy the system, they are the product owner. And they have to think about when I have to lock the system. And once they lock the system, that will be for at least 6 to 1 year. Maximum, they cannot lock more than 1 year. Because after 1 year, there will be new release, new security threats will come, new operating system will become. So that's why these are the things that we have to consider when we are designing our telemedicine roadmap. Thank you.
Okay, thank you for this presentation. We are now 15 minutes behind the schedule, so we'd like to invite the next speaker, Dr. Madam Upadaya, right? He is the Chief of Quality Standard and Regulation Division of Ministry of Health, and also Head of Digital Health Division and also Ministry of Health. So please, the time is yours.
Thank you. I'm honored to be here. Thank you, Dr. Uday, for inviting me. It was very wonderful presentation by Rajendra sir. We came to know about the roadmap. And now it's the turn of ministry. The presentation might be on behalf of ministry, but there are several things on behalf of me as well. So where ministry stands regarding the readiness of telemedicine, what we are doing. Since 2 days, yesterday and today, we have had several speakers, and there are several challenges or bottleneck came out, which are earlier Dr. Uday shared with us. So we have experience and we have been enriched with huge IT information for 2 days. So my presentation will be very small, and there are several things which have been shared earlier. So to speak about telemedicine, we must be aware of digital health, and it is the part of digital health. We are working on telemedicine, and as a clinician, I think this telemedicine is being done 24/7 by the clinician when they are at home, or they are driving, or they are working in any health institutions. But it should be systematic, and it should be owned by the government. And there should be one way of delivering the health, or there should be the information stored somewhere else for the future purpose, which I think is lacking till date. So I don't want to speak much about digital health. And this slide regarding background is also, we are all familiar with this. We are here to achieve the health SDG goals regarding health. We know our country, we know our geography, we know our accessibility, we know our equity regarding health. We know the out-of-pocket expenditure, how huge is the out-of-pocket expenditure regarding health in our country, and what government is still focusing on. So, as we all know, this information communication technology in Nepal has been advancing day by day. We are in a global village. We know several things what our developed countries are doing, what they are advanced with technology, and we also are eager to use those technology in our country as well. So we are all aware with this. And this on those backgrounds, we had done something. We had some favorable environment with the document, but still we have to work a long way. As I'm sharing this slide, I think this slide has been shared earlier as well. We have our policy plans, periodic plans, our acts, all in our hand. But the main challenge is the execution, how we are working on it. So these due to with this, the government is very eager to implement or very eager to achieve the sustainable development goal through telemedicine or digital health. And we have several with us. And we have challenges as well. They are very key issues with us. We have the documents, we have the acts, regulation, guidelines, SOPs with us, but still we face the huge challenge or huge gap on it. I will say there is a huge room for improvement as well. It might sound good that we are all working here. There are several entities, institutions working on telemedicine. They are working as per their need, and they are, I will say, they are all focused, people-centered. They all want to serve the poor people with their expertise. But still, Ministry of Health and Population at present is not aware how many institutions and technology are being used to serve the poor people of Nepal. We are unaware. We are unaware with our own ministry as well. So there is no interoperability in the information. The huge challenge is interoperability. That doesn't mean only that one application or one solution doesn't speak with other. We ministry people also don't speak with each other. We are not aware of what we are doing. Sometimes one division is working with the digital health and another division is also working on the same field, but they both are not communicating. They don't know how we are working or what we're working. It's the reality. I'm sorry to share it. It's the reality. So it's I might be get some trouble speaking this, but it's the reality. So there are huge gaps and there are huge challenges as well, and there is a huge hope as well, because this symposium or this workshop is one huge milestone for us, because we all gathered in the same room. We all gather with very sophisticated ideas, some doable, some will be doable in near future. And there will be the pages with us, which will guide the government to walk along it. So what is the need of the people? And the huge problem is the investment, which already shared by speaker earlier from me. The investment is the other challenge for us. So the area where we have to work, it is the team building as well. Without the team, we cannot work. And I will say we are some sort of technocrats who do not speak each other. IT people think they are expert in telemedicine. We health people, we are expert in telemedicine. We too don't speak each other. Or I can say I cannot convince my IT guy, or IT guy cannot convince me what to be done. So that is the one challenge with us. So there should be some sort of language which could be understood by both guys. So that is one challenge I think we are facing now. And one next challenge is the focal point in Ministry of Health and Population. That means now I am, as you know, as you all know me, in introduction, they said that I am the head of digital health something. You know how many workforce is working in digital health in Ministry of Health and Population? Sorry, only one guy is there. One guy and me as a division chief. So what do you expect from Ministry of Population or government? Where is the investment? without human workforce, without your mind, how can your hand work? I could not understand. I could not figure it out. You might have an answer, but I don't have an answer for it. During the welcome event to the new minister, that means the outgoing minister, my first challenge was with the same thing, that with one guy, how I can deal with the digital health. That was my challenge. And that challenge is since last few years. So I just shared my pain with you, and I feel somehow more healed after sharing it. So we don't have an investment plan, and the capacity building is there, and we health workforce to change it. It might be our thinking that when this new technology will come, we will be replaced. So that might be the other area where we have to work, where we have to convince our friends. And there are other several things, several areas where we have to work. So what Ministry of Health and Population thinks, there are the several areas where we have to work through telemedicine. But if we can work, and we are working on these headings, we are working on maternal care. We have worked much more in infectious disease during COVID pandemic. Somebody shared earlier, and they thank that COVID pandemic was there, so we can have strengthened our telemedicine. I heard something virtually they were sharing. So we can also thank COVID-19 pandemic because it strengthened digital platform. It strengthened our telecommunication, our telemedicine, our teleconsultations, our as you can name as you like. So we are working on this in mental health also. We have initiated. There are several stakeholders who are working on it. So these areas are the primary areas where we have to start, and we are working on we strengthen. Then we can gradually scale it up. And now only there are 2 slides, and I think there are 4 domains where there should be some thought, or there should be some thing we have to do for the betterment of our future in telemedicine. So we don't have Telemedicine Act, so it might be needed. The revision of guideline is needed because there are several flaws. There is a guideline which had been made during the COVID, so we have to revise it. And the documents are made, they are not the static, they are dynamic, so it can be changed. So we need the SOP for telemedicine, and there should be one high level regulatory committee in ministry or by the government where it can regulate all those sort of providers and all those sort of applications or services, and technical support team. We should not forget this. And regarding financing, as we all know, it should be linked with social health security program. There are several social health security programs. So the financing is the very key critical issue. So it should be assured. There would be the user fee for secondary and tertiary care, which is not covered by the health insurance as well. There should be some costing done. Telemedicine service, the services should be listed. What services can we provide through telemedicine? Yeah, we know, we have seen that telesurgery is also done. So all those things. There are certain institutions which are working with teleophthalmoscopy, otoscopy. They are being done. Consultation is done. We cannot do palpation, but we can hear the breath sound or cardiac sound through the devices. So it is so advanced. So there should be listing of all those services what should be provided through telemedicine, and they should be costed. And the program support should be through government. It might be in the regular annual work plan of Ministry of Health and Population. It might be from Science and Technology, Telecom, the program for this. and provinces and hospital itself should have some sort of programs regarding the financing as well. So the third, it might come first or it might be kept last. It is up to you, but the political commitment should be there. And I will say we are weak on advocating these with our political leaders, with, I already said, with intersectoral ministries as well, and 3-tier of governments. We have said, but we had not been successful for this. So the political commitment and the strategy for universal health coverage should be advocated, and there should be resource generation should be done for telemedicine as well program. So political commitment is in third, and the last, we can say we should integrate telemedicine with our EHR. Health record system, there should be incorporated. The implementation guidelines should be based on WHO. There are some benchmark or some exemplary guidelines which guide us to run the activities of the program. So WHO guideline and technical trainings to implementers as well. And I have listed the last point about awareness and advocacy among the technocrats. It's a very difficult term, technocrats, I'm sorry. Because I cannot convince, or I already said, we cannot convince the decision maker or policy makers. They might be bureaucrats. So what digital health actually is, what telemedicine actually is. Only having this screen, somebody is talking in front of you in a video conferencing, it might not be telemedicine service. There might be some sort of other architecture for that. So it's very difficult to convince our co-workers, our seniors, our juniors regarding telemedicine. So I have put this, sorry for that. So this is my last slide to you. There have been huge changes in the government. You can see when 2001, I think, how we started this telemedicine and how we are. So there has been a huge changes. We have achieved a lot, but there are miles to go. There are huge room of improvements to be done. And we are here, we can work together and the changes can be made. Thank you very much. Thank you for listening me. And this is the last presentation from WHO. Our national professional officers from WHO, Mr. Pawan Kumar Gimire, will be highlighting the WHO guidance and efforts for telemedicine implementation. Thank you.
Thank you, Chair. So I feel myself privileged to be here for this much awaited event that we were looking for from last several years, to have all the champions together in the telemedicine. So this is very good opportunity for us as well to talk on the telemedicine. This looks like the previous presentations, the planning, how to plan the telemedicine. So Ranji shared several steps. Dr. Madan also shared some government plans. This should be done by the government. So in the same direction, I'm presenting the WHO, how WHO have recommended and suggested the steps for telemedicine in member countries. So while we talk of the telemedicine, we have to take care of the use and accommodation of the ICT, information and communication technology, in the health system. So when we started the digital health, we have taken this as the very cost-effective approach for reaching to people and bringing the health service provider and recipients together. So it will obviously reduce the time, cost, and geographic barriers, and also help support to reduce the barriers and minimize the barriers. So telemedicine also taken as within the broader umbrella of digital health, and this is basically the barrier of geography and barrier of human resource shortage and other kind of things and specialties. WHO have defined this telemedicine in the same line as this is where the distance is the critical factor. The telemedicine use of ICT for bringing people and health service together, and also to reaching the unreached and having universal health coverage to accelerate on this, and also the SDG. The telemedicine is also adopted as very much good tool for having the USC. So within this framework, WHO is promoting the telemedicine as well. And this COVID have also provoked all of us to have the telemedicine, because at that time we had a limitation in the mobility, limitation in the physical presence and interaction for the health services. So when we talk about the WHO chronology, basically it was WHO have thought all this in 2005, but when the e-health strategy came out, then in 2013 we started talking on the external and interoperability. Then in this way, in 2020 we found this consolidated telemedicine implementation guide for the member countries. The 2020, so why so late? I think this is because the COVID situation have encouraged, and also there was very big demand of telemedicine during those periods. So WHO was pressurized to provide some guidance on this telemedicine. Though came late, that's good. This guide suggests telemedicine plans to have to complete in 3 phases. So first phase is the situational assessment, then plan the implementation, then monitoring, evaluation, and have continuous improvement. So we have to follow these 3 phases, phase-wise approach for having this complete the telemedicine implementation programs. This guideline does not talk in the nitty-gritty and how to design, what software to use, how to make the processes, but it simply suggests we have to have a SOP, we have to have governance, so things are there. So this is the broad outline of the plan. So let us see how our plan fits with this one. So first, in this part of situational assessment, it is suggested to have first build the team and establish the goal. So several times we are talking, having some steering committee, technical working groups, support teams. So everything comes here to have the very good team to initiate with the telemedicine programs and establish the goal, how to reach the people to whom we are going to reach, how many people and services will our coverage of the telemedicine. So setting the goal and scope of the program that should be done before while situation analysis. Then also we have to have some health program context and target. Which health program we include in our telemedicine services, and what should be the context for that one? Whether we are also taking care of emergency services, or only we talk of the basic health services, or primary care, or some kind of services of mental health. So let us define the health program and the context and targets as well. The third step suggested is to do the landscape analysis, what is going on in the country. WHO guidance have suggested to scratch and start from the beginning. That suggests to do some landscape analysis, know the situation, what we have now, and start from there, what we have now. So in Nepal also, we have several telemedicine projects. So we don't go for making the foundation and going on that. Just we start from there where we are. So for that, we need to have some kind of landscape analysis of telemedicine in Nepal. So this is also planned. This is also planned by Ministry of Health, and assess the enabling environment. So this is the one of the enabling environment. We have lots of people together. Yesterday we had so there are societies, agencies. We have external development partners who are supporting, and the policy environment is there. We have some laws to initiate with the telemedicine and to have some strong telemedicine system. So we have to analyze the enabling environment of what we have in the country, and also the education and digital literacy that is very going strong in Nepal. That may be also one of this enabling environment. So in the second phase, we go for planning for implementation. So in this context, we have to analyze how our telemedicine system will operate. We don't imitate or make copies of other systems, but we have to develop our own and define our system, how our telemedicine will operate, which technology we use, how to use. So this all comes in this step. And then we talk of the safety of the patient and also the professional safety of the service providers. So this is not happen. This is not happen. We don't have any document that says the degree of safety to the patient, and there is no personal safety guarantee of the services providing through the telemedicine. So there should be. And then establish standard operating procedure for several things. Like while we talk of the telemedicine, there are two components, tele and medicine. So SOP is needed for both tele and medicine. So we should have combined SOP for several things, not only one SOP work for all. We may have SOP by services, we may have SOP for technical arrangements. So it's suggested to have establish some standard operating procedures. Then we should have client patient engagement, and we should be aware of that. After having these telemedicine services, whether we are going to limit the access of the people or we are going to increase the access of the people. Sometimes the technology that limit the access to services, that is happening in some places, in some systems. When we launch some digital technologies and system, the people who cannot use that one, they are marginalized. So we have to take care in mind that whether our system will increase and promote the equity or that limits the equity, that kind of thing we have to think, and human rights and other conditions have to be taken care of before, and we also have to consider all this. For that, we need client patient engagement and have their opinion be collected before planning the telemedicine. Then budgeting should be done in the implementation phase. That is a very critical factor. How much cost we have to the project incur, and in the long run, what support we need, from where we are getting the funds, and how to make how we can generate the revenue for the sustained telemedicine programs. So that is one of the tips suggested in this guide. So lastly, there should be some monitoring evaluation framework for that one. With some indicators are suggested how our telemedicine program goes ahead, and how we monitor, how to set up the monitoring and oversight mechanism, and then how we measure the goal, progress towards the goal. So this is all about the implementation, how we are going on. Then lastly, there are some presumed and anticipated risk of having telemedicine, and issues are there. Then we have to have plan how to mitigate them. So I'll show a few of the presumed risk and then the issues in the telemedicine, the guideline have suggested. First, in the leadership and governance, a lack of governance mechanism and regulatory, that may be the one of the first issue that should be done by establishing a team and having a structure for this one. Then we should have a strategy and investment in this domain. The insufficient resource may be a risk. After having a telemedicine project 1 or 2 years, then we may not have fund for maintenance, and then that collapse. So sufficient resource. For this one, it shows that we have to embed the telemedicine in the health system, not as a project differently in the isolation, but the health system that should have telemedicine in their organogram, their system, their process, and structure. Telemedicine should not be done on the as per wish. That should be part of the health system. So it suggests if we have a telemedicine in the system, our system organogram and our whole of the service package, then it will sustain and the budgetary issues will be solved for the long run. Then there is another issue, how we do reimburse for the services. The health service providers are providing the services. There is no any mechanism to reimburse them. So we have to have this one. Then we may not have a lack of telemedicine regulation. Then legal liability across jurisdiction is one of the factors. Nowadays, we hear that some hospitals in Nepal, they are having communication with Apollo Hospital and other in Delhi or Bangkok or Singapore. But we have to check whether that is regulatory or not, whether that can be done or not. If we contact any of the hospital in Nepal, they contact the hospital in Bangkok, the law of the Bangkok applies to that. Thailand government law is applied to that. That is their services. So crossing this legal jurisdiction, we have to have some kind of communication and some engagement with them to have this one. Data protection and privacy is always the issue in the telemedicine as well. Patient, they should be ensured of their data privacy and their data protection kind of thing. Then infrastructure, whether our services is accessible by all in the sense of universal health coverage, that should not limit any people for getting the services. So this comes here, and we have to take care of this one. And for this, we have to have different modalities for different kind of people. For the disabled, for other kind of people, how our telemedicine services we design. So we have to take into consideration different condition of the people. Then workforce, the major factor here, the change management, the resistance from the health worker that may come. Obviously, with the traditionally working health workers, they may not accept easily the telemedicine. So for that, from designing the telemedicine program, it is suggested to engage them, the health worker themselves, and find their comfortability, their acceptability to the telemedicine programs. Then there may be some low-level engagement, like we plan for 1 week, all daily telemedicine services, but the health workers, they may not uptake that services, and they cannot run. They do not run. They may not wish to run. So it should be taken care in advance. Then quality of care and medical liability. What the quality of care we ensure with the telemedicine services, and what with the medical liability to the health professional they are providing the services. So there are some mitigation measures that is supporting with the training, and then services where quality is not compromised with the telemedicine services. If we go for complex services, then there may be some issues over there. So start from where we don't have to have compromise with the quality. We can have some clear guidance on the quality control. Then risk of privacy and security breach prevention is there. So we have to mitigate some of the application. If we use some inferior kind of software and some network and some kind of applications, then we may have this kind of problem in the future. So we have to use some robust software from some valid sources, the very good digital health products to use in the telemedicine services, so that this kind of privacy and security breach kind of things will be protected. Then last, the fragmentation of the digital health landscape we are having here. We are having fragmented approaches. So, to be aware of that, and for that, some standard and interoperability would be set by regulating agency to have all the systems together, and we should not say these are fragmented. So these are the presumed risk in the telemedicine services. We may have many contextual, but these are the common issues found in the telemedicine services. So this is the last, I'm talking of how we started some digital health kind of thing. In 1958, we started telephone reporting from the field officer for malaria reporting. Then gradually in 2005, 13, and 2018, we have WHO World Health Assembly resolution on digital health. So in 2020, 2022, we have now the digital health guidance from the WHO, and in 2020, we have a global digital health strategy. So all these things are going on. There are maybe some intervention missing, but these are the broad I've listed. So first telemedicine, I have here said 2004, but Ryan was saying 2001. So this is because we don't know each other's intervention. Yeah, this is happening. So in future, I think after following this guidance and having going with Dr. Madan's plan, and as suggested by Rajendraji, we'll have very good telemedicine plan for Nepal, and that will sustain for years. Thank you very much. Thank you.
Thank you all. Sorry, I would like to interrupt. So because we are running out of time, actually I had requested many of you to be present. So maybe we'll have informal discussion after we close the formal session. And we have got very young and energetic leader in ministry. And in his leadership, our digital health will grow, and we are all here to help you, to be with you. This declaration we'll be sharing through email or other services, and you can add your comments or suggestions in this. And Arun sir also has provided me this digital Nepal framework for health. This also I will be sharing with you all, and we can have discussion continued. With this, I would like to request Dr. Moriyama for the closing remarks, and then we'll have informal discussion. Yes, Dr. Subhas. Because of the time, I think after closing, we'll open the floor maybe, because we have many questions. I know that, but Dr. Madan also has already cleared so many things. So, yeah. Thank you.
All right. Okay, thank you for joining our 16th Asian Telemedicine Symposium with us. Surely that maybe through these 2 days intense time, we're able to share our knowledge and experience in telemedicine. Before the pandemic, our telemedicine is mainly focusing on doctor education to share the knowledge just between the doctors or nurses or something like that. But this time you are able to watch the various attempts, challenging achievement of telemedicine, mainly focusing on doctor to patient or doctor to patient with nurse, right? So this is a dramatical changes through the pandemic. Something was happened in recent few years. Unfortunately, something was a pandemic. But anyway, in some countries, the telemedicine is becoming more advancing, and now they can be one of the leading country of telemedicine field, maybe. So, including us, Japan, we'd like to learn from a lot from those countries. And I'd like to talk a little bit about the Nepalese situation. So I sincerely appreciate the Dr. Udaya to have this kind of good opportunity to get together. Maybe this is the first time opportunity to get together from medical sector and governmental sector and company sector. Something has just happened here, right? This is maybe the start of the telemedicine in Nepal. And through the discussion in 2 days, I learned and I realized the enthusiasm of doctors and the social contribution of companies and some issues to be solved from the government, maybe. But I believe you can solve this problem and go forward to the telemedicine. And then I believe you will be able to one of the advanced country in telemedicine, because you have very strong needs of telemedicine. That's why I believe you can be the leader in this field in the near future. So thank you again for joining us for 2 days. And this Asian Telemedicine Symposium is actually annual event. Next, we will organize this symposium in the end of this year or early next year. Detail is not confirmed, but we surely said which we will hold this symposium somewhere in the world, right? Okay, so but I hope to meet you again in the next ATS and hope to hear the proceeding of telemedicine in Nepal. Okay, thank you again and see you again. Thank you.
Thank you. Now informal session will start, and maybe some of our seniors are busy because of the APAN, they have some program, so they can leave. Okay, Dr. Suvas wants.
मेरो 2-3 point. First point regarding the resolution. हिजो एउटा important कुरा आएको थियो कि for the sustainable development of telemedicine, the program has to be incorporated in National Health Insurance Plan and other insurance plans. Only then it works prolonged. Srishti addressed that point, and that should be incorporated. One point. One query to WHO represented, not representative. Okay, Pawan sir. What is the support plan from WHO in technology and funding regarding the development of telemedicine? That didn't come. You only mentioned budgeting is required. So many expect those things from WHO, so we need the answer. And third point, Rajendra sir ko bhanaima alikati mero healthy comments ke cha bhandakeri regarding उहाँको e-health को development को कुरा गर्दाखेरि we should not forget few names: Midas, Dafe, Mediflow, Dolphin, Hamro Doctor, and many more. And the first health mobile app in Nepal is Hospitals Nepal. Because मैले तपाईलाई भनेको आमाको मायाको पटक पटक कुरा आयो, with due respect to आमाको माया, but you should, as an advisor, you should maintain those unbiased presentation. That's my input, if I'm not wrong. Okay, thank you. Ask Foundation, I know.
Yeah. So that is why Telemedicine Society is there. So we will include all of you.
Thank you. Yeah, this was also a question I was looking for, how WHO support. So basically WHO don't have such big fund for investing in the projects. There are some policies. No, that is not the case. That depends on the context. WHO policy is that for the fragile health settings, we don't have in Nepal such settings. So in the fragile health settings, WHO also goes to the service delivery level. So for those countries, there may be some possibility of funding to the extent below extent. But for the countries like Nepal, WHO provide the guidance. They provide the technical assistance for this one, but don't provide the hardware, some kind of software, don't purchase the softwares, but they provide the technical guidance, and also they can provide the experts if we need for Nepal to establish the telemedicine system. So this kind of soft programs can be supported by WHO, but don't expect much for the low stakes too much. Thank you.
Thank you, Pawan.
दाइको सुरुको इन्सुरेन्सको कुरा गर्दाखेरि मैले मेरो प्रेजेन्टेसनमा राखेको थिएँ, दाइले देख्नुभयो होला। टेलिमेडिसिन अथवा हाम्रो टेलिकन्सल्टेसनलाई चाहिँ जबसम्म इन्सुरेन्स प्रोग्राममा ल्याउँदैनौँ त्यसलाई हामी नेपाल सरकारले तिर्न सक्ने हैसियत राख्दैन अहिलेको लागि चाहिँ। त्यसमा हुनुपर्छ, त्यसमा हामी काम गर्दैछौँ एज अ बोर्ड मेम्बर अफ हेल्थ इन्सुरेन्स बोर्ड। हामी चाँडै नै त्यसको सल्युसनमा चाहिँ आउँछौँ। र यसमा समस्या कहाँनिर भन्ने कुरा छ, गभर्मेन्टले सबै अस्पतालहरूमा इलेक्ट्रोनिक मेडिकल रेकर्ड सिस्टम लाने भन्ने कुरा छ। केही हदसम्म केही पाटोमा चाहिँ दाइले नाम लिएका सबै संस्थाहरू, सबै अस्पतालले कुनै कुनै किसिमले त्यो सल्युसन अथवा एप्लिकेसन राखेका छन्, गरेका छन्। त्यसमा एउटा ठुलो च्यालेन्ज भनेको इन्टरअपरेबिलिटी नै हो। त्यो ठुलो च्यालेन्ज छ। इन्टरभेटिभ ल्याब हामी कहाँ जिआइजेडले मिनिस्ट्रीमा इस्टाब्लिस गरिदिँदैछ, उसको सपोर्टमा आउँदैछ, त्यसलाई फङ्सनल कतिसम्म बनाउन सकिएला अर्को च्यालेन्ज त छँदैछ। तर सुरुवात चाहिँ भएको छ, इन्टरभेटिभ ल्याब चाहिँ जिआइजेडको सपोर्टमा, जर्मन गभर्मेन्टको सपोर्टमा चाहिँ मिनिस्ट्रीमा ह्यान्डओभर हुँदैछ। एउटा इन्फर्मेसन सेयर गर्नु खोजेको मैले। र त्यो सँगसँगै एपिआई मार्फत चाहिँ इन्सुरेन्स प्रोग्रामहरू चलिरहेछन् अहिलेसम्म। र यो ल्यायौँ भने सबभन्दा पहिले हामीले गर्न बाँकी अरू पनि काम छ, कस्टीको काम हामी सायद सकाउनु पर्ला, टेलिमेडिसिनबाट दिने सर्भिसहरूको लिस्टिङ हामी सकाउनु पर्ला, नभए चाहिँ इन्सुरेन्सले कभर गर्ने के भन्ने कुरा गर्दाखेरि हामीसँग अहिले भएका थुप्रै सर्भिसहरूलाई त एकैचोटि इन्कर्पोरेट गर्न नसक्ला, राज्यले धान्न नसक्ला। त्यो धान्ने किसिमले हामी कुरा गर्छौँ। इनिसिएट चाहिँ यो वर्ष चाहिँ हुन्छ। हस्,
Thank you. Thank you. Here is Dr. Rana Bogatif. He's from Rolpa Hospital. When Dr. Madan is here, so maybe you want to share something.
धेरै कुरा त नमस्कार सर, धेरै कुरा त अब मैले हिजै पनि भनेको थिएँ। एउटा इन्टेन्सन टेलिमेडिसिनलाई कसरी स्टार्ट गर्न सकिन्छ, नेपालमा कहाँ कसरी गरेको छ एउटा एक्सपिरियन्स लर्निङको लागि र आफ्नो ठाउँमा चाहिँ त्यसको सुरुवात गरौँ भन्ने एउटा ध्येयका साथ आएको हो। अब धेरै कुराहरू त हजुरहरूबाट सिक्ने मौका पनि पायौँ र अब यो जुन सुरुवात गर्न चाहेको एउटा इन्टेन्सन छ त्यसलाई चाहिँ एउटा मूर्त रूप दिनलाई हजुरहरूको सहयोग चाहिँ एकदम चाहिन्छ। र हामी जस्तो दूरदराजमा काम गरिरहेको चिकित्सकलाई यो एउटा बुनको काम गर्न सक्छ। त्यसैले हामी दूरदराजमा बस्ने भनौँ न अलि फार अफ डिस्ट्रिक्टबाट चाहिँ स्टार्ट गरिदिनु होला। यदि गभर्मेन्टबाटै यो कुराहरूलाई चाहिँ लागू गर्ने होइन, अब बजेटिङदेखि लिएर अन्य ल मेकिङ, अब यसलाई पनि हेल्थ सर्भिसको एउटा पाटो नै बनाउने हो भनेपछि हामीबाट चाहिँ गरिदिँदाखेरि यो अझ सहज हुने थियो, हामीलाई सहज हुने थियो त्यहाँ काम गर्नमा भनेर चाहिँ चाहन्छु।
Thank you. Dr. Dheeraj from Baitadi Hospital.
Thank you. Good afternoon, everyone. I am working at District Hospital Baitadi. I'm a MDGP, and as I mentioned yesterday and today as well, we are facing different problems. We are mainly having problem with referral of patients to the centers, to tertiary centers, because it took at least 8 hours to send the patients to Dhangadi. So if we will be privileged with this telemedicine center, at least one hub center in the Sudur Pasim province, then it will be very kind to the population over there. So that's my request. Thank you.
Thank you. Dr. Raju from Spinal Injury Center.
Yeah, actually, our tele-rehabilitation system in our hospital is a bit different because the tele-rehabilitation, there are so many telemedicine, but tele-rehabilitation still I didn't see the listed even here in anyone's presentation. But Uday sir has mentioned rehabilitations while giving that to the Ministry of Health and Population. So we basically, this is very important for the people with disability and people who cannot reach to the hospital. And we have started tele-rehabilitation system from our center to the patient's home. You know, they even it is very difficult to travel those people from their place to even the hospital. So we have provided that service at home. So now I can the same thing I like to request, like Dr. Subhas, like it should be the tele-rehabilitation services should be in the insurance system. Then only we can grow this tele-rehabilitation system or telemedicine system in country. Thank you.
Thank you. Dr. Bijendra Joshi is Medical Director at Manu Model Hospital.
Thank you, Dr. Uday, for your kindness. From yesterday's and today's meeting, we have learned a lot. And today we are very fortunate that Dr. Madan has given his precious presence among us. We have seen many improvement in these days in field of telemedicine. While I was also working through this since 2008 with Sarojit Alsar. And what we feel is everybody is trying, everybody is doing, but we are lacking some coordination. And now the time has came that we integrate all these things. Some are trying to be our best, some are regulating, some are seeing many hopes in future, and even already told in his slide that ministry has a plan, and just need is the integration of all these things, and we can look forward for bright future of telemedicine in Nepal. Thank you.
Thank you. Here is Dr. Arun Nyobani. He is one of the important person during CCMC. We all know Arun, sir. Please, sir.
Thank you. मैले भन्नुपर्दा चाहिँ बेसिकली जुन मदन डाक्टर साहबले इनेबलर्स भनेर दिनुभएको थियो अघि, मैले हेर्दाखेरि अल द इनेबलर्स आर इन प्लेस जस्तो लाग्छ हैन। एन्ड स्पेशली मैले यो 2 दिन एटेन्ड गरेँ बिकज आई एम फ्री दिस डेज, and I found that the need is there, the enthusiasm is there, the support is there. So you are not alone. त्यो 2 जना मान्छेलाई चाहिँ 2000 बनाइदिनुस् हैन। You call anyone from this, Dr. Saab is there, everybody is there. There are a lot of young guys who want to do something in life हैन। Keep a name, nation को सर्भ गर्ने छन् के, टिम छ के तपाईको पछाडी, तपाई फुल पावरले अगाडि जानुस् न। There are so many people to help you. That's what I felt है मैले। तर you have to look back and ask for help है हैन, बिकज अब कसरी थाहा पाउँछन् र अरूले नभए हैन। आफ्नो आफ्नो काम सबैले गरिरहेछन्। यसो एकचोटी पछाडी फर्क्यो भने तपाईको 10 जना मान्छे आइपुग्छ मलाई लाग्छ है। Seeing the enthusiasm and the thank you very much.
Thank you, sir. Here is Dr. Sailendra from Armed Police Officer, Police Hospital. He has been working in telemedicine for years.
Yesterday and today, all the sessions were quite interesting, and everything has been covered. Everybody are working in piecemeal. These all work should be integrated, and there should be an umbrella, what I think personally. So all these, whatever ahead, a policy or something like that, umbrella should be there, and it should incorporate government as well as private, all the organization. That's all.
Thank you. Here is Kavin from Ask Foundation.
Hello, everyone. It was wonderful session from yesterday. And I would like to suggest, like, it's just a recommendation, if we have some foundation or like a legal foundation framework for implementing any telemedicine or digital health. So all the stakeholder, either private or public stakeholder, can work a lot. So there is still like a dispute, and there is still like confusion among us, like how to move ahead, like because there is no clear-cut guideline. So if we can work together and form a consortium on this, so we can give a proper direction for among us ourselves. Thank you.
Thank you. Here is Dr. Rajkumar from Dhulikal Hospital.
नमस्कार सर, म हिजो प्रेजेन्ट गरिरहेको थिएँ रुरल हेल्थ केयरको बारेमा। त्यसमा मैले पर्सनली गएको केही हप्तामा चाहिँ जुन जिल्लाका साथीहरूलाई फोन गरेर सोद्धाखेरि धेरै ठाउँमा चाहिँ टेलिमेडिसिन भनेको सेटअप नै छैन। भने कति ठाउँमा पहिला फङ्सनल थियो कोभिड अगाडि, त्यसपछि त्यो केही कोभिडको टाइममा चाहिँ अर्कै कामको लागि युटिलाइज भयो, त्यसपछि ब्याक टु द सेम सेटअप छैन, अनि त्यो फेसिलिटी धेरै ठाउँमा हराइसकेको छ। सो आई थिङ्क अब रुरल हेल्थ केयरलाई हामी प्रायोरिटाइज गरेर चाहिँ एक्सेस हेल्थ केयरको एक्सेस चाहिँ टाढासम्म पुऱ्याउँछौँ, स्पेसली केयर पनि प्राइमेरी हेल्थ केयरलाई फोकसमा राखेर भन्छौँ भने जिल्ला अस्पताल अनि त्योभन्दा मुनि लेभलको जुन रुरल हेल्थ केयरमा प्राइमेरी केयरमा जुन पार्टिसिपेट गर्छन् त्यो सेटअपहरूलाई चाहिँ पक्कै नै इम्पावर गर्नुपर्छ होला। र आई रिक्वेस्ट टु मेक सम रेगुलेसन एक्ट अर फेसिलिटी बजेटिङ एभ्रिथिङ फर रुरल हेल्थ केयर। थ्याङ्क यू।
Thank you. Yesterday's theme was the role of nurses in telemedicine, and Karka is running home-based care, nursing care, so she will speak.
Thank you, sir. Namaste, sir. लगभग प्राय सबै कुरा नै आइसकेको छ। यसमा चाहिँ अब यो जुन हिजो र आजको जुन सिम्पोजियम ले चाहिँ यो वर्कसपले चाहिँ नि जुन एउटा ट्र्याकमा लानुपर्ने हो त्यो कुरालाई चाहिँ नि सबै साइडबाट सपोर्टिभ हिसाबले नै अगाडि बढ्छ भन्ने अपेक्षा राखेको छु। थ्याङ्क यू।
Thank you. Here is Dr. Sushil Koirala. He is also very much enthusiastic in digital health.
Thank you, Dr. Uday. Namaste, everyone. I couldn't attend yesterday, but I really feel full of enthusiasm after attending today's conference. let's check this momentum. And in the coming fiscal year budget, I would like to ask Ministry of Health and Population to put in the President speech. राष्ट्रिय कार्यक्रममा राष्ट्रिय नीति तथा कार्यक्रममा चाहिँ टेलिमेडिसिन चाहिँ हाम्रो टेलिहेल्थ चाहिँ एउटा प्रायोरिटी रूपमा आओस्. दिस इज आवर फर्स्ट निड. र अघि भने जस्तै एसओपीज र लेजिस्लेसनमा चाहिँ अब जहिले पनि कहिले के हुन्छ नि, कहिले कानुन पहिला आउँछ, चिज पछि आउँछ, कहिले पहिला टेक्नोलोजी आउँछ अनि कानुन बनाउँदै जाने हो. लेट्स क्याच इट अप. र यो जुन सिम्पोसियम बनेको छ यसले गर्दा जुन ड्राइभ यो कोठामा मैले जुन इन्थुजियाजम भाइब्स फिल गरेको छु, यो एनर्जीलाई किप गर्दै वी आर अल विथ मदन सर एन्ड टिम. Let's make it happen. Hey, thank you.
Thank you. Here is Srisi.
Thank you, sir. मेरो क्वेसन चाहिँ अलमोस्ट कविनले लाइक करेक्ट आदि त सोधिसक्नुभयो. थ्याङ्क यू कविन, क्वेसन सोधिसक्नु भएकोमा. मेरो क्वेसन चाहिँ सबै WHO, हस्पिटल, गभर्मेन्ट सबैलाई छ कि लाइक कति धेरै एप्लिकेसनहरू बनाएको छ, रिसर्च पर्पजेसको लागि बनाएको छ. हिजोको प्रेजेन्टेसनमा, आजको प्रेजेन्टेसनमा पनि देख्यौँ कति धेरै मेडिसिनको एप्लिकेसन, EHR, MHR यति धेरै बनाएको छ होइन सर. अनि एकरूपता छैन, सबैले डुप्लिकेसन गर्यो भन्ने कुरा आइरहेछ होइन. एन्ड वी डोन्ट नो वेयर टु गो और वेयर टु सिक, ताकि एकरूपता आओस् अनि हामीसँगबाट कलेक्टेड इन्फर्मेसन पनि एउटै ठाउँमा बसोस्, सो डुप्लिकेसन नहोस्, इन्फर्मेसन पनि लस्ट नहोस्. अनि त्यसको लागि चाहिँ के गरौँ भन्ने चाहिँ मेरो सजेसन हो सर. थ्याङ्क यू.
Yes, thank you. Here is our Vice Chairman, Pawan Sakeshwar.
Thank you, sir. I would like to repeat my question. So when you think of telemedicine, isn't it the appropriate time that we think of digital health rather than just telemedicine? Because when you think of digital health, we can encompass lots of things like M-health, E-health, whatever health we talk about. And when we think of digital health, there are three main important steps that we have to consider. One is digitization of medical, so that we can gather data out of it. So when we have data, we call it health informatics. So when we combine the equipment and the health informatics, it becomes knowledge repository system for us. And when we think of implementing the digital health system, I think it's high time we should start from the health post, not from the ministry or, not from the municipal hospital. So that like, let me give an example, if time permits, sir. Okay. So we've been working in Dullu municipality, and recently we visited one of the remote health posts. It's in ward number 18. From there, it's almost 5 hours walk to the Dullu municipality hospital. Then we came across paramedics who knows how to run ultrasound machine. But because of the policy and guidelines, he's not able to check the patient by using ultrasound machine. Okay, so when we think of the digitization of ultrasound machines, you can at least check the patient and the file can be sent to the doctor in Dullu Municipality Hospital. Okay, so that's one of the examples how we can make the digital health initiative effective and efficient. Thank you, sir.
Thank you. Here is Dr. Pooja Lama. She is Information Communication Officer and Public Health Specialist, working in Public Health Concern Trust.
Thank you, sir. I don't have a question, actually. I have an answer. धेरै इन्स्टिट्युसन्सहरूबाट चाहिँ इन्स्टिट्युसनलाइज गर्नु पर्यो डिजिटल हेल्थलाई, टेलिमेडिसिनलाई भन्ने कुरा हिजो त आएको ठिकै थियो, आज पनि आइरह्यो, र सफ्टवेयर रेगुलेसन सिस्टम. सो आई वुड लाइक टु वेलकम यु अल टु टेलिमेडिसिन सोसाइटी अफ नेपाल. हामी एकचोटि नभएर हामी चाहिँ नि तपाईहरु सबैलाई समेटेर बारम्बार घचघच्याउने काम डेफिनेटली गर्छ. सो जस्ट जोइन अस इन आवर फोर्स. थ्याङ्क यू भेरी मच.
Thank you. Thank you. She is also our treasurer, so she is asking you to join. So I think Dr. Madan will conclude and we'll have the closing.
Thank you. Thank you, Dr. Uday, and thank you all. एकदम ऊर्जा मिलेछ आज. अरुण दाइले एकदम सही भन्नुभयो. एकजना ले धेरै गर्न सक्छन्. त्यो एकजना अगाडि देखिने मात्रै हो, पछाडि ठुलो वर्कफोर्स हुन्छ. मैले अघि हेल्थ वर्कफोर्सको कुरा गरेँ. एकजना टेक्निकल मान्छे हुनुहुन्छ र त्योभन्दा अगाडि प्रेजेन्टेसनमा पनि हामी दुईटाको भाषा मिल्दैन भनेको थिएँ. नेपाली बोल्नुहुन्छ दुईजना, हामी नेपाली बोल्छौँ. अब यो मैले खासै धेरै व्याख्या गर्नु परेन। यहाँ सबैजनाको कुरा सुन्दाखेरि हामी सबैले नेपालमा भएको टेलिमेडिसिन प्रविधिलाई सरकारले अपनत्व लिदियोस् र ती दूर दराजमा भएका जसलाई सेवा चाहिने हो उनलाई सेवा दिन सकियोस् भन्ने चाहना हो। त्यो हाम्रो दुर्गमबाट आउनुभएको डाक्टर साहबको होस् तथा हामी यहाँ सुगममा बसिरहेर सेवा दिने हामी व्यक्तिको जसको भए पनि त्यही चाहना हो। यसमा यो 2 दिनको सिम्पोजियम वर्कसप र यहाँहरूको विचारले पक्कै पनि मन्त्रालय र म व्यक्तिगत मलाई पनि एकदमै ऊर्जा र बल मिलेको छ। आगामी दिनमा हामी सँगै नै काम गर्छौँ। म यही फ्लोरबाट यहाँहरूलाई पनि आह्वान गर्छु, हामी सँगै मिलेर अगाडि जाउँ र यसमा पक्कै पनि यहाँहरूको साथ रहनेछ। मैले उहाँको एउटा कुरामा के भन्ने भने सठिक ठाउँ भेटिएन, धेरै किसिमको एप्लिकेसन भयो, कसले कसलाई दर्ता गर्ने अथवा कसले कसलाई चलाउने भन्ने कुरामा तर दुर्भाग्य स्वास्थ्य मन्त्रालयलाई त्यो बजेट छुट्याइएको छैन खासै। त्यसले गर्दा अब टेलिमेडिसिन टेलिहेल्थको बजेट उता भयो भने त्यसलाई कसरी गर्न सकिएला हैन? त्यो एउटा समस्या हाम्रो बुझाइमा छ। त्यसले मैले अघि नै टेक्नोक्र्याटलाई अवेरनेस एडभोकेसी भनेको थिएँ। त्यो यस्तै यस्तै कुराले गर्दा भट्या हो। यी शब्दहरू अलि मेरा लागि चाहिँ घातक होलान्, तर ती पिपुलको लागि चाहिँ एकदम सार्थक होस् भन्ने चाहना हो। किनभने हामीले सरकारलाई जगाउनु पर्यो। हामी सबै सरकार हौँ एक किसिमको, र हामी सबैले आफ्नो जिम्मेवारी निर्वाह गरेका छौँ। त्यसलाई जगाउन सकियोस् भन्ने नै चाहना हो। र यो 2 दिनको सिम्पोजियमको जे जस्तो निचोड निष्कर्ष आयो त्यो निष्कर्षले सायद हामीलाई टेलिमेडिसिन अब पनि गरेनौँ भने सायद ढिलो हुन्छ कि भन्ने चाहिँ हामी सबैले बुझ्न सक्यौँ भने त्यही नै ठुलो हो। र हामी सबै जिम्मेवारीमा यो रोटेसन हो हैन, यो म्युजिकल चेयर हो हाम्रो चाहिँ हैन। तर एज अ पब्लिक जहिलेसम्म हुन्छौँ त्यो सधैँ त्यही बेसमा सेवाग्राही सेवा प्रदायक दुईटै रूपमा हामी बस्छौँ। त्यहाँ चाहिँ पक्कै पनि हामीले एडभोकेसी राम्ररी गर्न पर्छ र आगामी दिनमा हामी सँगै जान सकौँ, सबैको विचार लिएर अगाडि बढ्न सकौँ। र यहाँहरूको साथ सहयोग भयो भने स्वास्थ्य मन्त्रालयले अबको नीतिगत रूपमा कतिपय कुरा गर्नुपर्ने छ भने कतिपय कुराहरू व्यवहारिक प्रस्ट्याइहरू पनि चाहिन्छ, त्यो प्रस्ट्याएर अगाडि बढ्न सकौँ भन्ने नै चाहना सहित यहाँहरूको उपस्थिति र यो सिम्पोजियम वर्कसपमा डाक्टर उदय लगायतको टिमले जुन यो अवसर दिनुभयो म उहाँलाई पनि धेरै धेरै धन्यवाद दिन चाहन्छु। एकदम आभारी छु र यहाँहरूको विचारले साह्रै प्रेरणा मिलेको छ। आगामी दिनमा सँगै काम गर्न सकियोस् यही मेरो चाहना छ। धन्यवाद।
हस् हस्, थ्याङ्क यू। अघि म्युजिकल चेयर भनिहाल्नुभयो। साँच्चीकै मिनिस्ट्रीमा र यो डिभिजनल हेल्थमा म्युजिकल चेयर नै। आज एकजना भेट्न गयो 6 महिनापछि अर्कै लिड हुन्छ हैन, 1 वर्षपछि अर्कै लिड। र हामी सबैको चाहना चाहिँ डाक्टर मदन, बिकज हि इज यङ एन्ड हि इज, अब मैले त भनिसकेँ भविष्यको सचिव नै अब भनेदेखि जहाँ गए पनि हि सुड लिड, एटलिस्ट त्यहाँ घचघच्याइराख्ने काम चाहिँ एटलिस्ट डाक्टर मदनबाट होस्, हाम्रो त्यही चाहना हो। हस्, थ्याङ्क यू, थ्याङ्क यू।
Thank you very much. Thank you, sir.